Good morning. Greetings to colleagues who are online. I'm colleagues here in Boston at Fenway Health. Kenneth Mayer, I'm the research director here at Fenway, professor at Biomedical School. It's my pleasure to introduce my colleague, Dr. Ingrid Bassett, who's going to introduce our keynote speaker today.
Super. Welcome, everyone. And thank you, Dr. Mayer. And thank you to the Fenway for hosting us today. Welcome to everyone online as well. If you have any questions, please put them in the chat and we'll get them to Linda-Gail and their talk. So it's an absolute pleasure to introduce Dr. Linda-Gail Bekker. I can think of no one better equipped to speak at our Harvard University Center for AIDS Research Grand Rounds on the case for combined HIV and sexual and reproductive health services. Linda-Gail is the Chief Executive Officer of the Desmond Tutu Health Foundation and Director of the Desmond Tutu HIV Center at the University of Cape Town. We all know her as an extraordinary physician scientist, advancing public health through her cutting-edge and very creative community-based research, including as PI, the landmark study showing the epidemiological behavior for young women and girls. I am lucky enough
to move the program maybe to the
papers with planning to science being here for half hour response to a digital age review with her, write the papers with her, to see her in action with her team in LA. And what stands out to me is her incredible drive to elevate people, to see their potential and their humanity, both the people she serves and through her research and her colleagues. We are so delighted to have this extraordinary advocate with us today. Please come up, Linda-Gail. Welcome. I'm sure. What happened to my hands? And apologies, voice left. I want you to imagine, and this is, I don't know if anyone in that room uses home delivered animal boxes. It's the subject that few here. So we have something called UCOR. And that is just incredibly innovative because it arrives pre-selected, it's taken, it's convenient, and all the needed ingredients are in one box. Only what you need in a fresh. They are step by step, sort of immediate instructions. And when we put it together, it comes out by picture to the Lancet. There's no wastage. It offers new opportunities in scalable and sustainable growing in South Africa. And the alternative is, the difficulties of shopping in multiple stores, buying too much, finding wrong ingredients, not finding it's so that's just really a salient sort of analogy of what I've been talking about. I'm going to remind you that we are talking about and they had an HIV illness. I thought it's about today. That's all. And all of these we have seen changing annual new age infection by region as sort of where we have list the that other slide should have shown. We haven't seen incidents for not seen and when we got to 2020, what was not implemented was particularly prevention around key populations. We missed our targets for adolescent girls and young women, and a number of other targets, including around condom provision, PrEP, VMNC, etc. And so, we were anxious in 2020, having missed those targets. And of course, in 2024, you really do see a flat line in terms of reducing the infection rates more than we should have done by 2020. And I would avoid it because really, we do have an amazing number of prevention tools. But I reflected back to
8 years ago, right in hospital, just to remember that, we do need to combine and this goes all the way back to the early 2000s, thinking about behavioral change and social justice, as well as the body. We see advanced in biomedical
difficult.
and
How's the shot is around corner?
I don't want to write that there is more to motivation than just that. Here is where the explosion has been biomedical response to prevention. And we do now have, in addition to monthly long-acting rates and 6-monthly long-acting rates, and all coming monthly goals, annual rate, it really is a national explosion.
Yes.
So that now, and I love this analogy, get trust.
That's much.
And anybody can, whoever sort of draws out into a station, can receive what they need, encourages
I can switch. I can switch camera one to the slides if you want that.
Also to use RV, we can put together what they need for prevention. So what I'm describing here is layering prevention interventions for better. And so here's a quick flash through of what we can do for adolescent girls and women, what we can do for men of sex with men. And data is showing us that layering has a better effect in a complementary way. So again, going back to this Lancet series way back, and see who the sex workers. We use this socio-ecological framework. But the first layer was that of the sort of individual and the behavioural and the biomedical interventions for the individual. And you can see a real array of layered prevention options that are available now for sex workers. And a modelling work that was done in this paper showed that when you add things together, you get better. And so the first basic area is layering prevention opportunities for better effects. And I'm giving Lancet a good plug here. There is a commission entered in 2018, which spoke about, it's a commission that Chris Barr and myself and a number of commissioners here even, when we thought about global health and strengthening HIV response in the era of this sustainable development goal. One of the big messages here was around integration. For students to have better outcomes. And again, a bunch of modeling studies were done here, not a single on people who use and inject drugs. This was modeling that in 2 regions or cities in Russia, showed that over half of new infections and HIV-related deaths could be averted if harm reduction was scaled up with art in arms. And a further 1/3 of infections and overdose deaths could be averted again by combining options. And of course, conversely, failure to scale up harm reduction and scaling up of art only would have less impact on averting HIV incidence and overdose. And there's real world examples of how this works. We all know about the famous Vancouver studies, which have shown, because of the incredible harm reduction policies, a huge reduction in HIV incidence in Vancouver, Canada. Interestingly, Mike Cohen and team has actually gone into this to say, is it all the antiretroviral rollout that has contributed to this reduction in incidence? And in fact, their conclusion is this wouldn't have happened without harm reduction. So the point is, layering prevention is very important in its own kind of way. And my last example, because we want to bring it back to STIs, is this one from India, also in that commission, showing that when we combine antiretrovirals amongst MSM and female sex workers in India, again, there is a reduction in HIV, an impact in MSM and an impact in female sex workers, and adding PrEP in a zero-negative kind of approach. So data is showing us that layering has a synergistic effect. And you can say, sorry, can you project again, bigger bang for the buck when you layer? And so this is a beautiful study out of Kenya again, in people who use magic, which are that by providing harm reduction, including opioid substance therapy, you actually get increased antiretroviral coverage and better viral load outcomes. So hence, sort of making this point, in addition to HIV incidence was increased, but you're getting bigger impact. And then this study, which inspired drew my attention to it, was talking about that when we offer PrEP to transgender folk, we see a better uptake of exposure profiles. So pay attention to that. So the question I now want to pose to you, if we go beyond prevention area for treatment area to integration of services across diseases. So moving out of HIV and saying what about patients' needs overall. So do we get better outcomes? Do we enhance treatment, prevention, and care outcomes by doing so? And the word integration came under a bit of a spotlight at Kigali. I don't know if anyone here was at the IS meeting. And this was really in the aftermath of the fighting cuts. There was a big drive, particularly in East and Southern Africa, that key populations had to go back into the public systems. So PFAR, USAID, these entities have really created community-based structures. And the response to losing that was go back into the clinics and integrate. So there has been, I want to raise it because it's provocative and controversial. This word integrate has become a little bit of a sort of bad word. And I wonder if we can rather think about bundling as a concept. So can we bundle services and bring them together in such a way that people actually come out with a better package at the end of the day? And the UNAIDS is just as hard as fulfillment. And I'm pleased to say there is a bunch of work going on integration. So not only are we looking at prevention targets, different targets, but we're actually having integration targets as well. That exercise. We've had a full process of what all the things that could be funded with HIV. These are just things of. But I'm going to really concentrate on sexual health and reproductive health today. And perhaps the one case where this work very much was in our response to reduce vertical transmission. And this was particularly related to the global plan to reduce vertical transmission, which ended sadly in 2015. So up until 2015, we came with a very integrated program to reduce vertical transmission in Africa. But you can see the plan ended, and then the whole thing fell apart. So here is when we take integration out of the reach, we sort of see an antithesis. Or maybe the response here is what else do we need to do to bring this to an end. And here I'm going to raise now a lot of the vertical transmission is happening not in positive women. You knew they were positive when they came, but women who become positive during things. So raising the question of what we're doing around prevention to prevent vertical transmission. Do you also want to say, I'm talking about prevention, but all of this has to do. We know that retain.
What's that?
Prevention is very hard to because services on what they need, all difficulties. And here's the prevention cascade, where you can see we aren't doing well in terms of respect of people. And there are many reasons why people may not persist with pre-exposure prophylaxis and HIV prevention. Stigma coming into it, services that aren't suitable. In the case of what's happened recently with the final freezes, the real reluctance to go into government facilities. Feel that was so there. Beautiful job in really outlining all of the reasons, individual, health system, and structural, that stop people using the services that they need. And I've sort of outlined in red what really, I think, raises the question of, can we be doing this better? Can we be providing care that removes some of the barriers that we're talking about? And we've been encouraged to say, let's concentrate not only on maintaining the cascade, but actually improving the quality of the cascade, because it is then that we are likely to hold people in our care. So this is about putting people at the center of our services, providing good health-related quality of life. And it talks about differentiated service delivery. So I do think bundling services falls squarely into this notion of differentiated service delivery. And if we remember nothing else, when we walk away from here, if we could just get this message out to everybody that we need to provide differentiated treatment, prevention and care services that go beyond HIV health facilities and conventional venues to ensure those who are aging, HIV advanced, young, criminalized, marginalized, busy, are all served in order to end this epidemic. My animation isn't working, and I'm not sure why that is, Amir. My animation isn't working at all. So this is a shame because people aren't seeing the layers. I'm talking about layers today, and none of the layers are working, which is a shame. Anyway, I'll keep talking. Below this is the helix of seronegative and seropositive care. So it says we have a seroneutral approach, and we. It does not matter whether you are negative for STIs or positive for STIs, negative for HIV or positive, whether you're pregnant or not pregnant. You move down the cascade and everybody gets some service because sexual reproductive health and is just, it's sort of central to everything. And sort of underpinning all of this, and this is the Guttmacher Commission, again published some time ago now, which reminds us that sexual and reproductive health is a state of physical, emotional, mental, and social well-being in relation to all aspects of sexuality and reproduction, not merely the absence of disease, dysfunction, or infirmity. There are also normative recommendations coming. So I don't know if you know, WHO now is HIV, sexual health or STIs, and hepatitis. So they're all in one combination. They've just thrown TB in there as well. So we are going to get guidance now that combines all the diseases. So I think this is step one, that our guidance kind of draws us or brings these services together. The IAS for a long time has been pushing person-centered care in the form of differentiated prevention and treatment. And as I mentioned to you, UNAIDS is now talking about targets. And you can see a new target that is coming forward here is that 95% of people who are receiving HIV prevention or treatment should also receive reproductive health services. Now, whether we're going to be able to monitor that, whether we're going to be able to reach these targets by 2030 remains to be seen. Finally, our users, our people we provide for, tell us that they want a one-stop shop, particularly young people. Integration is huge for them in terms of the services that they need. So, for the second half of this, I'm going to talk about adolescent girls and young women because that's what I really know and that's the sort of area I work in most. And we asked many years ago, where, who, how, and what should we be providing in terms of their care and services? So I think the recipe here is you recognize the population, in this case, adolescent girls and young women, assess their needs, bundle the services, and platform that you're going to give from. So who are these young women? Well, they're in trouble, basically, even in 2025. Fewer are finishing secondary school than their counterparts. Bacterial and viral STIs are incredibly common. Most of them are unemployed or have vulnerable employment. Young women are having sex, frequently sexual debut, typically at the age of 16. Without vaccination, 2/3 will acquire HPV. 2/3 of new infections occur in sub-Saharan Africa, threefold more than male counterparts. 80% of all people living with HIV who are adolescent girls and young women live in sub-Saharan Africa. And 50% have been pregnant before the age of 18. They really don't have access to contraception in the way that they should, and we'll be hearing more about that today. Poverty also shapes risk and access to services. I want you to think, when I think about sexual risk in young women, it is all about HIV, STIs, and unintended pregnancy. That encompasses their sexual risk. And poverty really drives and it, makes it far more complicated. But here is my model for how to approach young women and girls. It's all about sexual reproductive health and mental health and economic empowerment or their futures. And really, if we can sort of solve this, I think we will really change the trajectory. I raised the fact that many, many women are pregnant before, they reach kind of young womanhood. And they are using contraceptive, typically long-acting, but there is a high rate of pregnancy. We have shown that seeking out contraception is a great way to snag them into HIV prevention. So there is this synergy between seeking out contraception or family planning and then being able to access HIV prevention. In the same way, STIs draw them into our clinics. A lot of young women are having condomless sex. A lot of them are having sex with positive partners or unknown status in partners. And of course, I've already mentioned that many of them are becoming pregnant. The rates I'm talking about are sort of through the roof. It's up to, 1 in 2 young women will have chlamydia when they come to our services. This is pre-PrEP, so it's not because we've kind of liberated them to have condomless sex. This was happening long before PrEP actually came along, and the vast majority of these are asymptomatic. In the onset of PrEP, we are also seeing that this is an opportunity to find STIs and treat STIs. So in this particular PrEP project, amongst 15 to 19-year-olds, 1 in 2 had an STI. And this is work that Connie Kellum has done. And I really just want to point out that HPV is as much of a threat in these young women, and we just don't have enough access to HPV vaccine. So when we've done these PrEP programs, what we found is that STI awareness is very low. Ignorance is incredibly high. There's lots of misconceptions, but people are incredibly hungry for good information and gain-frame messages. So what do adolescents want? And this is really what we ask them. They want adolescent-friendly services with appropriate info, tailored to them, confidentiality, opening times that suit them, and comprehensive services. So everything they need in one solution. And it's getting rid of the hassle factor. When we ask them where and how would you like it to be given, the words like friendliness and non-prejudicial, tailored, fast, from a mall or a mobile, was what they said to us. So that brings the question of where. When it comes to adolescent girls and young women, there are a number of places where we can make contact with them throughout the life course. And these key entry points are very important. Less so for young men. So that's important to remember. We don't see young men in our services and in places quite to the same extent. But I do want to point out they're captive in school, they're captive in colleges. So there are other opportunities to find them. But when you look at the life course and you take that adolescent section, you can see they're on media, they're having a lot of time with their peers, they have a little bit of employment coming in, lots of education, and they spend time with their families. But all the rest of the time is in the community. Do you see clinic here? You don't see clinic, so you've got to bear that in mind when you're thinking, where am I going to see these people to bring out the platform? So I've inserted clinics because we can't get away from clinics, and clinics are important. So we have done work to say, can we make clinics more amenable to a layered, comprehensive service? And the way we've done this is, one, to offer a sort of cash incentive, but to make the services as friendly as possible and to make sure that they're comprehensive. And what we found is when we make them comprehensive, and this is together with Nora Rosenberg in Malawi, we see better uptake of services, HIV tests, condoms distributed, etc. And people, young women say, at the neighborhood clinic, you get shunted around, and the wonderful thing is, here we get everything in one place. So again, people respond to say this is where their needs are met. Adolescent-friendly services are much enhanced when there is a peer service around. So that really bring home the importance of the peer navigator and trained, sensitized nursing staff who are not discriminatory. And so that, again, when we look at traditional clinics, back to the sort of pros and cons approach, the pros are that they're obviously there, but they need buy-in. And this is where it can be a problem. Staff buy-in can be difficult, staff turnover, space is limited. Youth are very skeptical about going in there. And of course, it's not exclusive to youth, and services too often are fragmented. Let's turn to the community and non-facilities. So we've tried a complete standalone parallel system, a youth centre, providing comprehensive sexual reproductive health services. And this certainly is great. And when you talk to key pops in South Africa today, they will tell you this is what they love. The drop-in centre that PEPFAR has been funding and USAID has been funding, where it really provides the comprehensive kind of care that they need in many ways. Dreams, the PEPFAR program, was doing this. However, there's an affordability issue here. Sustainability, as we learnt on the 20th of January, those services disappeared overnight. They often, don't have government buy-in. As we've also discovered, government is not rushing to replace the drop-in centres. And of course, it is all about sustainability. So what about mobile services? And the Desmond Tutu Health Service has really used this. We now have a fleet of these brightly coloured Tutu teen trucks and Tutu testers, Amajita men's trucks, women's trucks, whatever you like, they're out there sort of doing their services. And you can see we can provide an extensive menu in doing this. The youth love it because, there's social media, there's fun, there's often loud music, and they love the biometric anonymous service. They don't have to say their names. They put their finger on a finger pad and immediately their history is available to the healthcare provider. We can also bundle, which is amazing. So no one's telling us what we can and cannot do. We can provide contraception. We can provide HIV prevention, including injectable PrEP. And we've done haircuts, we've done nails, we've done hair braiding, whatever it takes to get people into the service. People need to be able to make choices when they have a menu, and so we've also explored things like decision menus, ways for people to choose not only family planning choices, but also prevention choices. So the pros here, of course, are they're tailored, they're youth only, they're very accessible, community-based. Again, there's a sustainability issue. We're an NGO, we have to raise money to do this, and we don't always have government buy-in. Today in South Africa, there are about 50 or even more mobile trucks sitting in garages as a result of USAID funding going away. So they are sitting in garages not being used. Very sadly. So what about school-based? Again, school is a great place to find young people. College would apply. In the same breath, young women and girls, and this is lovely work that Audrey Pettifor did some years ago in South Africa, that pregnancy was found to be both a cause and a consequence of school dropout. So it's really important to try and keep people in school. And one of the ways to do that is to provide contraception for them. It is really important that they easily access contraception. Just want to say there is an experiment happening in South Africa at the moment where HPV is being rolled out in schools. And now that we only have to give one shot, it's really got a whole lot easier. And it's been shown this is entirely feasible to be able to give out HPV. We've tried to include other kinds of strategies like sport. And here, this is soccer, grassroots soccer coming into schools to say, can we get people's attention? This is Goals for Girls. And certainly using other ways in school to hold people's attention and then offer sexual reproductive health services. Again, feasible. And I'll just in the interest of time, I will say the power of peers here. So that the soccer is done with coaches and peers who bring navigated, strong empathic relationships, which have been shown multiple times to be valuable to young people. The Zemeli program, which was a huge global fund program we did in 20,000 adolescents. We went into schools, 50 primary schools, 45 secondary schools, and we provided a number of programs in those schools, including school health services in the schools. And the schools could choose. They could have type A, type B, or type C. A was everything: HIV testing, contraception, STI management. B was everything except HIV testing. It turns out HIV testing is a trigger for parents and communities. And then C was just wellness, guidance, and counseling. And headmasters could choose what they wanted, and the school governing bodies could agree on what they wanted. And what we found was that over time, more and more schools went to A. So they saw it was feasible, it was useful, less girls were getting pregnant, and there was huge excitement. And these nurses became very, very important in the schools. The learners at schools are faced with lots of social issues. People are sexually abused. I feel like I'm making a difference. So it was an enthusiastic response. Unfortunately, in the Western Cape, we had a change of government, as one does, and we had to stop our school program. But I'm pleased to say we've again had a change, and we're back in the schools, and it's working very well indeed. So there is a little bit of sort of reliance on policy, which can be problematic. But otherwise, I can say schools and colleges are a fantastic place to come in and provide sexual reproductive health services. Finally, how? This is another part of Zemeli, which is around 19 to 24-year-olds now. So these are young women who can no longer get social grants. And I want to make the point that their big problem is they're hustling for survival. They're unemployed. They have no prospects. They've often had 1 or 2 kids by now. And their choices are incredibly constrained. When people say, why aren't they just, getting contraception or getting PrEP? This is because it's survival on a daily basis to just sort of eke out their existence. So we said, we will provide this for you in a very accessible way. And if you use it, we will give you a small cash incentive to do this. Just a little 300 Rand at the end of a session where they had to come, decide if they would also test or pick up their contraception. And we would give them a little test. It was a randomized control trial. 10,000 women, 5,000 got the incentive and 5,000 didn't. And what you saw is that there was a 60-fold increase in the women who were given a little cash transfer. So it made all the difference. We didn't retain the women who were not given the cash incentive at all. So I come back to now saying, if we can address these 3 pillars in young women and girls in a tailored way that says we are all about harm reduction, we want to gain framed self-care, better health through normalized behavior and demedicalized services. And that's exactly what young key pops are saying as well. It's not just adolescent girls and young women. They need their sexual reproductive health lives framed in terms of their daily lives. They need to perceive them. They do see themselves as healthy. And so we need to meet them at that point. So my last piece, and I know some of you know about this, and we're incredibly excited about this program, where we went to young people and we said to them, and these were young key pops as well as young women, we said, well, how would you design a real sexual reproductive health service? What do you really do? And they said, we love social events where there's fast food. So we love chicken. What is it called? Kentucky Fried, and McDonald's, and, Chicken Licken and whatever. And we get it together, and it's quick and it's accessible, and different people can do different things. It's a great way of socializing, and there's lots of choice, and it's quick and fast. So we made fast prep like fast food. So you can initiate your sexual reproductive health services in a clinic or a truck, a mobile, and thereafter you can pick it up just about anywhere else. So inspired by Ingrid, we now park our mobile next to hairdressing salons. We send it in the post if they choose to have it couriered to them. We go to schools, we go to colleges, we are everywhere and anywhere, and we provide this menu, which is very feasible from these various places. We've tried to make condoms as cool as possible and rebranded them with a great bunch of young German guys. And we've really tried to make the environment as friendly as possible. We have now reached almost our target of 25,000 people. We're on 22. 17,000 people have started PrEP. Everybody else is accessing sexual reproductive health services more broadly. You can see the mobiles are more popular than the facilities, and there are a number who use the courier system. What we have found is that people are persisting. They're using the sexual reproductive health services for longer. They're coming back because it's so accessible for them. We're finding that there is a lot of sex going on. No surprise. A lot of condomless sex with lots of STIs. Syphilis is on the rise. But contraception is also being used, and this, of course, is really important. I want to point out there are other models. So here's pharmacies in Kenya that are doing very similar things. They're also finding that it's highly acceptable for people to come in and get their sexual reproductive health services, particularly emergency contraception. So this is Kenneth Ngura's work, really emergency contraception together with HIV prevention being very possible. So I know that in our mini-series, we talk about the MPTs that are on their way. And obviously you can see this is going to be the next step in terms of providing multi-purpose technology that answers people's needs. And there's already the oral version of this. It's a little bit less accessible. These are large pills, and they come in a huge folder that you have to sort of put under your arm as you walk out of the clinic. So it's not quite where we need it, but it is the first step in multi-purpose technology. Finally, I'm wrapping up. Tailored approaches raise the science of choice. So people are going to have to choose, and we're going to have to choose. How do we bundle? What is the bundle? And here's my model for this, which really, again, goes back to that Lancet paper, which says there is layering we can do of interventions, and then there's bundling of services that need to be done. And we need to be aware that people have preferences. We are inserting now even more choices. Here it is to put injectable PrEP in, helped by these kinds of decision tools, but I think AI is going to be really important in the future. At the moment, we're using people. So counselors are trained to help people make choices. We're using quizzes and all kinds of ways to get people to be able to make a good choice. And what we find is if they're sure about their choice, they're more likely to stay with the methodology. So this has come out of our recent Cabaret program, where when they chose what they wanted and the delivery method they wanted, they were more likely to stay. 3/4 of them are choosing the injectable, so it's interesting to see where we're going to go with injectable PrEP. But we find that there are personalities of people, and their personalities come into play. So the person who wants absolute discretion might say, no, I'm going to stay with pills because I need it couriered to a venue of my choice. Somebody else who's very social might say, no, actually, I really want, a 2 monthly because I want to meet my friends at least 2 monthly at the clinic and do this in a hunting pack. But people will also change and switch. So it's really important to see that. We are preparing now for the real-world implementation of lenacapavir, which we're very excited about. And so it comes back to what are these suitcases. So I'm going back to the train analogy. You have the train, your carriage arrives, you decide which carriages this person needs for HIV prevention. And then what do you put in their suitcase when they get on the carriage? And this, for young women and girls, will include, without doubt, STI care, sexual health and reproductive health, as well as, I would hope, some mental health support, etc. And you can do that for every kind of population or person that might walk in the door. You need to then say, where am I going to meet these people and how best am I going to provide those services? And then I believe we will have the best coverage of all people and all exposures, which will result in reduced transmission of all of those problems. I'm going to end again now, not with sexual reproductive health, but with IDU. And this is my friend Sunil Solomon. And it's the blue sheds in India. And it's the most fantastic story again of bundling. So these blue sheds have been sort of popping up in India for people who use and inject drugs. And you can see the medication and the medical care is just one part there. All of these other things happening, including showers and toilets, to ensure that people get the best care they need. So my reflections are, we can get even more out of our new innovations by bundling for impact. This will need collaboration with key stakeholders, and the key stakeholders here include healthcare providers, policy people, funders, users. We need to think of the best platform to find these people. Will HIV sexual health integrate into family planning, or will STIs integrate into PrEP services? That's where we need to be thinking. Ensure the guidance, the SOPs reflect and provide the training and the resources. Buy-in from healthcare providers will need evidence that the investment is worth it. I promise you healthcare providers will complain when you tell them that you are going to bundle more stuff, so you've got to make it clear to them what they gain by doing this. Helpful if some of the additional non-clinical work can be task shifted. And here I want to say, to my North American and global North friends, there is just so much wealth in using nurses, lay healthcare workers, counsellors, peers to do this work. And so, really encouraging that kind of task shifting approach, which Africa has really had to rely on. But we have found that it's a better service at the end of the day. Whilst implementing, we need to review and adapt. Stop doing the services that aren't welcome and don't work. That's the other thing. When you add stuff, also take stuff away if it's rubbish. And monitor and celebrate the wins. Positive feedback goes a long way. And with that, there are many, many people to thank for all of this. I kept it short. I just want to thank the RHU. Totally every day reminds me that, Ubuntu is so important, that we are human because others are human. And I think if we approach this with that view of humanity, which I know all of you as people who want to see the innovate and better sexual health in people, that's what you want to do. So with that, I'll just thank you all and thank you for the opportunity. And I know I've rambled on. So that takes some questions. Yes. So, guys, you were going to feed us.
3 questions.
Great. Great.
If anyone has questions in the room, we're going to start with questions.
Or comments. I'd love to hear what your experience is with bundling or layering or combining, whatever you want to say. We're not going to say integrate for a little while. Thoughts? Ingrid.
I was just struck by your comment at the end about trying to encourage people in the global north to be more flexible about just delivering the services, because this is more of a comment, but just as someone working in South Africa for 20 years and someone working in the US, I'm amazed by how much more entrepreneurial and flexible people in South Africa are as compared to what people are willing and
yeah, and I think needs must, right? So when you've got 50 a queue down the road outside your clinic, you have to task shift. And we did that right at the beginning. We have 8 million people who need antiretrovirals. 6.5 of them are on antiretrovirals. Our clinics are congested. So if we don't task shift, and this is why I feel very strongly we don't push prevention people in there as well. Prevention should really be outside of our health facilities. And that means you've got to go beyond healthcare providers. And they can do it. Nitya Panapak and others in Thailand have shown that peers can give out PrEP just as well as anybody else. In fact, better, frankly better, because they understand, they're empathic. And, we just need to empower them to also now encompass sexual health and reproductive health as well. So, yeah.
You have one slide.
Services and this, and they
You had one slide where you showed a clinical decisions or a tool that looked maybe like a chat. I was wondering how, what the acceptance is like of online or AI-based tools.
Love them, right? They're young people like anywhere in the world. So everybody walks around with some sort of phone in their hand. Not everybody has a really fancy smartphone. Everybody is on WhatsApp. Everybody has access to Facebook. So we use it very, very much in fast prep. It is our main communication way. And there's a kind of chat bot as well, so they can ask Nurse Flo for help and understanding. And they love that. So it's information in my pocket, right? It's reliable, useful information in my pocket. And again, this is task shifting. If she can have made her decision in the waiting room before she walks in the room, the nurse's job is done. She doesn't have to, start all over. She just needs to confirm, how do you want this? What do you want? And how do you want it delivered? Done, So we have more than one. This one is not app-based. It's I forget the terminology. There'll be others, AI people, who it's available right away. You don't have to have data per se. But there's a mixture of these things happening. I will say there's an explosion. I recently had a Gates meeting where the feeling is that AI is the way to go. And so I think we're going to see more and more of this, not only in terms of the user, but also the healthcare provider. So a lot of healthcare provision help in the AI space. So I think that is the new frontier, without doubt. I don't think it's going to solve all our problems, but it's going to enhance a lot of this.
Thank you for this really fabulous presentation. My name is Justin Smith. I'm an actor at Public Health Studio here at Harvard. He presented two data ways about the success of additional cash transfer programs. And I think cash for the first data way. Was that for PrEP, or or that's for engagement care? I wonder if there's out more about.
Yes. So the first one that Laura Rosenberg and I ran in clinics was to encourage young women to come to an empowerment program, and we offered a cash. So there were 3 types of clinic. One was just adolescent friendly. The other one was adolescent friendly with an empowerment service. And the next one was adolescent friendly empowerment with a little cash nudge. I wouldn't say in any way replaced, transactional sex, or it was never that kind of amount of money, but enough to encourage somebody, get somebody's attention. So we built off that to build the Women of Worth program, where we went to this large number of women, and they one lot just had to come to the empowerment session and pick up sexual reproductive health services as part of that. And the other was come up to the service, which was 12 of them, that they could do over 3 months. And before and after on the biometric, they had to show they had come and that they had ended it. It was run by igniters, so peers ran the empowerment sessions. We showed that we could do it in large numbers, 5,000 young women, over a fairly short space of time. We did not retain the young woman who got nothing. We had 60-fold better retention in the young woman who came. And we saw better outcomes in transactional sex, in gender-based violence, in pickup of services in the woman who had the most sessions. So there was a kind of synergistic, you were more likely to come you are more likely to have sessions, you are more likely to have better outcomes. So, this question of little nudges, and I try to make the point, these young women, most of them have no income to their households at all. And how can we ask them to engage around health when they're freaking trying to survive, And this was 3,600 Rand, let me think. It's like $180. That's what they got for the 3 months, and that made all the difference. So it's not a lot of money we're talking about here. So there's a big push in South Africa to think about a minimum wage. And I wonder if there's some way we could link that to sexual reproductive health, so that we kind of kill two birds with one stone. In our youth service, in the health park, we had a system of a false currency. We called them tutus, and you could earn tutus through healthy choices. So if you picked up your contraception on time, that notorious for being late for their contraception, we would give them tutus. Or if they helped somebody else, or they ran a session on good nutrition, we gave them tutus, and then they could cash in the tutus. And that was another way. We found we normalized HIV testing, so much so that, you got a tutu if you tested. I had to start saying, you can't test more than 3 monthly. It doesn't make sense. Stop testing. Because they would stand in the food queue because they could hand in tutus for a hamburger. And a 19-year-old male would say, who hasn't tested? I'm a bit short. Can somebody go and get a test quickly? I mean, it completely normalized sexual reproductive health by using a little incentive like that. So, yeah. I wish we could get our governments to pick it up. Yeah. Keep publishing. Keep hoping.
There are questions online?
Yeah.
Sure. And last year, well, it was unbelievable and really inspirational. When you showed, we have shown together, I think, that everything is here now that we need in terms of tools. And the ability to implement in this scope way, which will be different in Cape Town than it is here, than it is in Thailand. I guess the question we hear now about implementation science research. And luckily, they have here's a vaccine, right? This is a medication, so maybe you will take it. So the question is, how do we move from really focusing now on cure and vaccine research and things that have been going on and on and on, and allow or help funders realize that this is for these illnesses now where we need to put resources into understanding how it works. And yes, basic science, we heard yesterday how I understand it has to led to where we are, but this shift to social science and motivation science can get there.
Yeah. I mean, I'm hopeful that there's enough money in the world to do both, just because I really think there is enough money in the world to do, and there are probably two pots of money, by the way. So it is all about policy and ideology. Frankly, it's politics, because there's enough money in the world. And I think, though, what you are describing is we have a moment now. I loved the 2024 UNAIDS report. It was the urgency of now. Little did they know what was coming, 6 months later. But the urgency of now is something we all have to embrace, is that we can do a lot now. We can bring this epidemic by 2030 into control as a public health threat. And that I think we have to see as our goal. Eliminating HIV off the planet is going to need cure and vaccine research or a lot of time. You're right. Today, 120,000 children, acquired HIV. Those kids need ARVs for another 75 years. So we're in this for the long haul, but we can stop it becoming endemic, which is what I don't want to see as a person who lives in a world of endemic TB, where we have become, it's normal. The fact that all of us have a positive man too in Cape Town is not normal. I have to tell that to the community. That's not normal, and we have to get to a point where we don't think it's okay and normal that people are acquiring HIV. So I think we have to get to a point where we bring it under control. And you're absolutely right. We have the tools today. We need the political will and we need the resources. And then we need to get smart. How do we do it in the most streamlined, most organized way. And I suspect I haven't completely met Ken's expectations because I haven't told you how you should bundle sexual and reproductive health services. We're going to have to work that out for each of us, in our areas, and it's going to matter from population to population. I will tell you, I was so sad when everything fell apart at the NIH because we had a protocol in the works to enable healthcare workers to sit in a room and be agnostic, but tailored. So she sits in the room, and if a young transgender walks in the room, she goes, tick, tick, this is the bundle I need. If a young adolescent girl walks into the room, she goes, this is the bundle I need. And, it's streamlined and it's programmed and it's organized and it's on tap. That's the world, I think, where we can see not only the end of HIV, but a healthier adolescent population. I honestly think, sure, there are those who have sickle cell disease or chronic rheumatoid arthritis, but the vast majority are healthy, but they have mental health, sexual reproductive health, and, future prospects. That's what they need. And if we could just do that, it's not a lot to ask. And we're about to have the biggest youth population on the planet, on the continent of Africa. So if you're looking for jobs, it's the place to come. We've got a lot of kids happening in Africa. So it's really a great investment today to have healthy young people. They will be healthy adults and they'll be healthier parents in the long shot. Sorry, the guy's online. Yeah.
So we have questions from online. Thank you, Sally. Her question is, are participants given the choice of the bundle site or other ad entry?
Yeah. So it's bundled, but it's a menu. So they can actually say, many of them will say, I came for family plan. I just want family planning. I need my shot. And then this is the time for the nurse to say, yeah, but, have you thought about pre-exposure prophylaxis? Because, I noticed you had an STI. And this is a problem. So we need to really talk about, and can we show you these really sexy condoms we've got now? Maybe you can we counsel you about how you could ask your partner to use a male condom, etc. So she comes in for one thing, but then she's offered a menu and she selects what she needs from that menu. And it's really fun if she can also say, well, I'd like to have my nails done as well, or I need, half an hour of Wi-Fi. That just would make it really pretty cool if we could do that everywhere.
Just a last quick question for Raj online. Thank you for your inspiring talk and work. How are you building a dynamic choice in your programs?
Yeah, so again, that needs strong SOPs and guidance because it's confusing now, right? You've got tails, you've got time to protection, but we've written this all down so and it needs training. Nurses have made errors, and not to say I should have hold it. They haven't always got it right. So it's important that we do give them very explicit instructions. But the nice thing to know is that people can switch, and they do switch. And so that's important. It sometimes, and this starts getting into the details, it may be easier, for instance, to go from an oral to an injectable other than the other way around, because if they go the other way around, then they kind of locked into using an oral, unless they're going to protect themselves in some other way. We tell them that up front, so that they're very clear. If I'm a guy who's going to want to come on and off PrEP, then long-acting is probably not for them. And so the message, and this goes around in fast PrEP, is you can date oral PrEP, but you have to marry long-acting PrEP. And, divorce is tough. So don't go down that road if you're not entirely sure that you're ready to get married. Okay, great. Thank you.
Yeah, the slides.
Bring it back. Should I bring that back over?
Should we do next?
You just sit it up here. Okay, so okay.
Sit up there.
Yeah.
Miracles of modern technology. So we're transitioning from that fabulous keynote from Dr. Professor Linda-Gail Bekker to our Lancet Special Series Symposium. So I was really had the privilege, excuse me.
Yes.
Yeah. Is this better?
Yes.
Okay. So speakers know that we should be holding the mic. So it's really been a privilege to work with Professor Bekker on this series. And really, I have to thank a whole cast of thousands, many of whom are in the room, who put this together. So why are we doing this? So, Linda-Gail talked about this. This is going to be a theme of the day. Sexual and reproductive health are inextricably interwoven. No surprise to anybody. But for complex reasons, they often have been dealt with separately, and the separation is not helpful. So one of the things that really stimulated my interest in having this special series was the fact that traditionally there are two major international meetings, one on HIV, one on STIs, that happen every year. They happen a few weeks apart. They're in different parts of the world. It's not a good opportunity for scientists, many of whom are doing work on STI and HIV, to talk to each other. But there are even more reasons now, and we'll be hearing about some of the exciting new approaches that really say that we should be thinking about these issues together and how we can scale things up. And unfortunately, we're also living in a planet where the resources may be more limited, so we have to be smarter about how we use the resources to gain the most benefit for people around sexual reproductive health. Linda-Gail mentioned this before. There was a Lancet Guttmacher Commission report in 2018 that really talked in great detail about sexual and reproductive health and rights and the real importance of thinking about these issues together. But this really goes back several decades. WHO was talking about the importance and the right of sexual health and reproductive health going back a number of years. And the important thing is that we're talking about issues that can be seen as a deficit way, sexually transmitted infections, unplanned pregnancies, abortion. But really what we're talking about are things that are life-enhancing, and we really have to talk about issues that are not just absence of disease, dysfunction, or of infirmity, but have much more of a positive frame. And the premise is that people really need to have the autonomy to make decisions, to govern their bodies, and access services in the ways that they see that are most beneficial. But obviously, there are many challenges and many headwinds that we're facing, particularly over the past year. So this process has had a long gestation. There was a meeting in Cold Spring Harbor where I had the opportunity to talk with Dr. Miriam Sabin of the Lancet and Dr. Jeff Garnett, who was at the time at the Gates Foundation. We really realized that synthesizing the knowledge and where we are in the field and where the field may be going really could be beneficial for the scientific and clinical communities. The Gates Foundation generously provided a grant to support this work, and this led to an initial meeting in London at the Lancet in April 2024. So this has been a long process. And when we put the papers together, there was not a Trump 2 administration. We submitted the papers in January and rapidly had to revise the papers to reflect the new realities that we're all living through. So today we're going to hear from our President and CEO of Fenway. We'll be hearing from Dr. Sabin. We have the 5 papers, and you can see them summarized here. And then Dr. Bekker will provide a call to action. What do we do with all this new information? And our colleague, Adriana Bula in Fenway Health, is going to be giving a community response. And then we'll have time for questions and answers at the end of the program. I just want to thank, and I hope that they're online, our tireless project officers at the Gates Foundation, Dr. Griffiths-Mangaro and Erin Stonecipher. Miriam has really helped midwife this process. It's really required a lot of thought of how to really get the information out in the best way possible. There are colleagues at Fenway, Amy Rouse, Liza Rice, and Aisha Garation, who've really worked very hard to pull this together. And I want to thank Amir and his colleagues and other colleagues in communication like Chris Viveros here at Fenway, who really helped make this possible. So without any further ado, I want to welcome our President and CEO, Jordina Shanks of Fenway Health. Jordina has a career in clinical health as a frontline nurse, has a a strong administrative experience, and 20 years of leadership and executive experience in community public health, being the CEO of Planned Parenthood of Massachusetts and also of the Mattapan Community Health Center before joining Fenway Health in 2021. So, Jordina, thank you for being here. And without further ado, over to you.
Thank you, Ken. Good morning, everyone. We are incredibly honored to be hosting the launch of this series. And I just want to thank you all for being with us, both here in person and to those of you who are online. Fenway Health has been a trusted home for LGBTQIA+ health since 1971. Our legacy is built on innovation, courage, and community, creating healthcare services that didn't exist elsewhere and meeting people where they are with dignity and respect. From family planning to HIV treatment and prevention, from behavioral health to primary care, we've worked tirelessly over decades to make sure that care is accessible. What began more than 50 years ago as a one-day-a-week volunteer-run clinic has grown into a nationally recognized leader in LGBTQIA+ health and a trusted provider to more than 30,000 patients across Massachusetts and beyond. Fenway Health has advanced health equity, dignity, and access for LGBTQIA+ people and for all who seek compassionate, affirming care. Today, as our values and our communities face intense scrutiny, our mission remains constant. Our commitment to inclusive, affirming care for every person who walks through our doors has not wavered. Again and again, we have met uncertainty with courage and compassion, turning challenge into progress. Together with you, our community, we will move forward with purpose, resilience, and hope. Fenway Health is not only a healthcare provider, we are also a leader in research and education, pushing forward innovations in LGBTQIA+ health and equity. Across 5 decades, Fenway has been part of shaping the global conversation on sexual and reproductive health. Today's event, the launch of the Lancet's Innovations in Sexual and Reproductive Health series, continues that proud legacy. This series represents years of work led by our very own Dr. Ken Mayer, who you just heard from. Dr. Mayer is our medical research director and preeminent expert in HIV prevention and treatment. Under Ken's leadership, Fenway partnered with distinguished researchers and clinicians from around the world to produce this insightful collection of papers in the Lancet, one of the world's leading medical journals. These papers explore cutting-edge advances in sexual and reproductive health, including innovations in HIV prevention and treatment, contraception, STI vaccines, and multi-purpose prevention technologies that combine protection against HIV and pregnancy. Thanks to decades of scientific progress, antiretroviral therapy has transformed HIV from a fatal disease into a manageable condition, allowing millions of people to live long, healthy, and full lives. Yet, even as science moves forward, access remains incredibly uneven. Too many communities, particularly in low and middle-income countries and among marginalized populations everywhere, still face staggering barriers to basic reproductive and sexual health care. Globally, 214 million people wanting to avoid pregnancy do not have access to contraception that works for them. Even in the developed world, 21% of women in the U.S. report not using birth control because of the side effects. In 2023, lower and middle income countries received only $35 billion of $52 billion needed to fully uphold sexual and reproductive rights and care for all, leaving a critical funding gap of $17 billion. Protecting the sexual and reproductive health and rights of all people is essential to human development, and it is fundamentally a matter of justice. In fact, investments in sexual and reproductive health and rights pay off. For every $1 spent on contraception, saves health systems over $3. And HIV prevention programs save over $11 for every $1 spent. But instead of expanding the reach of these life-saving innovations, sadly, we are witnessing funding shrink, both domestically and globally. As governments shift priorities and politicize care, vital programs are being scaled back or defunded altogether. That makes the work represented in this Lancet series and gatherings like this one today more important than ever. In the face of these challenges, innovation is not a luxury. It is a lifeline. New technologies and integrated models of care can bring services to those most in need more efficiently and affordably. They can close gaps, cut costs, and most importantly, save lives. At Fenway, we believe that scientific innovation must go hand in hand with compassion, equity, and advocacy. That belief is woven through the work you'll hear about today and continues to guide our future. And with that, it is my great pleasure to introduce Miriam Sadin of The Lancet. Miriam is the North American Senior Executive Editor at The Lancet, based in New York City. She is responsible for The Lancet's North American strategy. The North American team, working with The Lancet's disease ambassador specialists, work to bring in the most impactful clinical and policy content in the U.S. and Canada. Please join me and welcome me.
Thank you very much for that introduction. Here we are. So, dear colleagues here in Boston and around the world, on behalf of the editor-in-chief of The Lancet, Richard Horton, I am delighted to provide just some very brief remarks to you on this Lancet series. I have had the absolute pleasure of being the editor for this work. Dr. Ken Mayer first shared his idea before Cold Spring Harbor for this series with me on a warm summer's day in Boston 3 years ago in an informal discussion. And here we are now. What was first just urgency and vision was realized. The thought of being able to work with Ken alone piqued my interest that day. But then, as you can see, the authors that Ken and the series co-lead, Linda-Gail Bekker, put together is an all-star cast in HIV, STIs, and all of sexual and reproductive health. In these days of mistrust in science, it is essential to elevate the voices and experience of scientific experts. It is no easy task, though, to put together a Lancet series, as I'm sure these authors will tell you. For those of you who may not be so familiar, though, with the Lancet paper series, these are important peer-reviewed bodies of work that aim to push forward an agenda within health. The goal is to shake the field up by sharing the latest evidence. Lancet series make impactful recommendations and strive to hold the various actors involved accountable for upholding their commitments to the populations that we all serve.
Lancet Series also bring together experts from varied regions and contexts to write the papers and want them to become invested in a shared narrative for a series that will resonate with policymakers, patients and clients, civil society, health workers, and others. Importantly, a Lancet series must also be timely and topical, and this series is most definitely both for those. Because global health financing, as we've already talked about today, is under attack. The gains made in the HIV pandemic, in maternal child health and reproductive health and rights, including abortion rights and LGBTQIA+ rights, are eroding, and harm is being caused. At the Lancet, we believe that everyone has a right to health, and within the U.S., as we know, the attacks are also just as serious as they are in the global health arena. Poor people must travel across states to have the same right to safe and legal abortion, which is an impossibility for many. The transgender community is under attack, with our own government trying to erase programs and transgender people of all ages. This Lancet series is so critical at this time for these reasons, but I am not interested in speaking only in echo chambers. Lancet series and this series is so powerful because it arms you with the data and recommendations you need to advocate for these integrated programs. It shows you what the costs are if governments don't act. It represents the best evidence to date on sexual and reproductive health. Therefore, I really encourage you to use the content of this series to get up to date or develop policy briefs for parliamentarians or other sectors with the evidence in these papers. I encourage you also to use the recommendations to track progress and hold governments accountable. Just use it. I'm sure you will all join me in congratulating Drs. Ken Mayer, Linda-Gail Bekker, and all the distinguished authors on this important series. I wish to also thank the Gates Foundation for funding this important work, and a big thanks to all the support from the Fenway Institute and Fenway Health for the series and for the event today. So thank you very much.
Thank you, Miriam. So, miracles of modern technology. We're next going to have the first paper presented by Dr. Andrew Gulick of the University of New South Wales. Because it's the middle of the night in Australia, this is not going to be live, but this will be an online presentation from Dr. Gulick. And he'll be discussing epidemiologic issues around sexual and reproductive health with some very interesting data.
Thank you to the chairs today for this invitation to speak to you this morning. My name's Andrew Gulick. I'm from the Kirby Institute in Sydney, Australia, and I'm very sorry I can't be with you this morning in Boston for this launch of this amazing Lancet series. My task that I was set by Ken and Linda-Gail was to put together an epidemiological overview which framed this issue. And we've titled this Partial Progress in Sexual and Reproductive Health and Rights, the Influence of Socio-Cultural, Behavioural, Structural and Technological Changes on Epidemiological Trends. Quite a mouthful. And I really would like to thank my esteemed group of co-authors who really took this challenge on with me. So it is now 7 years since the Guttmacher Lancet Commission was published in 2018. And that commission put together a very comprehensive review of what was required in the sexual and reproductive health and rights sphere, based around access, the need for universal access, the fact that this area should be seen as a human right, and that for the punitive laws would need to be removed, the need for investment, the addressing of structural and social causes of poor health with a particular focus on gender issues and stigma issues, the integration across sexual and reproductive health sectors, which we will be addressing later on today, and of course leveraging new technology innovations, improving education and communication, and lastly, holding governments and institutions accountable, particularly important since so many social and political actions are needed in this space. So my review has a really broad scope, and we divided the paper into 10 sections with the headings in this table. And this table contains the names of my international team of authors who took on the leadership of these sections. I thank them very much, and I apologise to them for having to summarise their sections in just 1 or 2 minutes each in today's presentation. So to start with, social and behavioural change. There has been continuing considerable change in this sphere since 2018. There is increasing evidence of fluidity in both gender and sexual identity, and particularly in the field of gender, their attitudes towards transgender people remain divided and may be increasingly divided in some settings. And of course, the biggest example of this is the United States, where the new administration has gone as far as directing federal employees to remove references to genders other than male or female in all of their communications. The continually rapid evolution of new digital technologies has really transformed access in how people learn about sex and also how they access services. It's really important to note that the way young people learn about sex is really changing fundamentally. The survey-based studies of sexual behaviour that have been covered at national levels have and these are almost all in high-income countries, have consistently described declines in sexual activity frequency, that's number of episodes, at the same time as they've found increases in partner numbers. And that increase in numbers is facilitated, at least in part, by online dating services, which have been a new way to meet new partners, most particularly at older ages. Moving on to political and structural changes. Before we talk about the last 5 years, it is important to really acknowledge that there has been decades of progress of reducing laws that criminalise sexuality around the world. But the last 5 years has seen some evidence of backsliding. So there are, and you see these on the map, 68 countries which criminalise same-sex practices. And on that map, the darker shades represent the darkest shades are those countries where the death penalty still exists for homosexuality. The white is countries where there is no legal sanctions. And you see there 6 countries which have increased punitive legislation recently, despite the very, very clear epidemiological evidence that those policies cause negative mental and physical health outcomes. And often those negative outcomes operate through stigma, which really drives that harm. And unfortunately, the evidence for effectiveness of reducing stigma is mixed, particularly in settings where those punitive policies exist. We need those structural changes before we can reduce stigma in those settings. HIV prevention is probably the best example of the fields that I'm going to talk to you today, where we've seen a response transformed by biomedical advances. That is, treatment is prevention, or its other half, undetectable equals untransmittable, and pre-exposure prophylaxis, with developments now leading to long-acting formulations. So globally, we've seen a 40% reduction in estimated HIV infections since 1990, which is reasonable progress towards the 90% UN AIDS target by 2030. But in 2024, we are still seeing over 1 million new infections. Interestingly, the biggest percent reduction has been in southern and eastern Africa, the areas which are worst affected in the world, with about 50% of new infections. And there are a small number of countries which are now approaching that 90% decline. But those are the countries where the response is mostly funded by international aid and predominantly through the United States USAID and PEPFAR programs. And so those success is currently under very imminent threat by those drops in funding. Outside of Africa, most of the infections due to HIV, about 80%, are occurring in key populations, such as men who have sex with men, transgender women, sex workers, injecting drug users, and criminals in prison. And those key populations are particularly targeted in the cuts. So, for example, PEPFAR funding for PrEP has been maintained for prevention of mother-to-child transmission, but has been stopped for all key populations. And before we leave the field of HIV, it is important to note that there are some areas, such as the Eastern Europe and Central Asia, Latin America, the Middle East, and North Africa, where we are seeing increasing and not decreasing HIV. Sexually transmissible infections, we are not seeing promising trends, although the data are rather limited compared to HIV. We are not seeing a declining trend in the 4 curable STIs, and internationally we're seeing increasing concern regarding drug-resistant gonorrhea. And the worry, of course, is that this may lead to gonorrhea becoming an almost untreatable infection, particularly if the extensively drug-resistant strains become established. Where the higher quality data on trends of STIs exist, and this is mainly high-income countries, we are seeing increasing incidence. So the top graph there on the right shows increasing syphilis in the US over the period 2014 to 2023, and the bottom graph from Australia, from my setting, showing a real tragedy of increasing congenital syphilis in Aboriginal and Torres Strait Islander people, consequent to increasing syphilis in gay men and then heterosexuals. And in fact, in many international settings, we are seeing increasing sexually transmitted infections in men who have sex with men. So this is a field where we really critically need new effective interventions such as vaccines. Cervical cancer and human papillomavirus is a field where we have that, where a highly effective vaccine really raises hope, if you like, of elimination. So in 2020, the World Health Organization released its global strategy to accelerate the elimination of cervical cancer with 3 targets as outlined there. So the first of those, for which we have some data in the graph on the right, is the proportion is a target of 90% of girls vaccinated by age 15. So you will see in the graph, none of the WHO regions have reached that 90% vaccination threshold, although we do have roughly 80% vaccination in the Americas region. You will see in red there increasing rates recently in the African region, but still much too low. Since 2020, the WHO has recommended a 1-dose program for HPV vaccination in girls, which is potentially transformative because it simplifies the health systems needed to get high rates of vaccination. The second target there is that 70% of women should be screened for cervical cancer twice in their reproductive years, and screening has now shifted towards a primary focus on HPV screening, even in low and middle income countries. This is the most sensitive form of screening and is more effective than other forms. The need for this to happen in low and middle income countries has led to a real push for point of care solutions to do this, which clearly don't involve the need for a pathology laboratory and are therefore more feasible. And the fact that we're screening for HPV now, which is a nucleic acid test, which is extremely highly sensitive, means that self-collection is an option for HPV screening, and it has been introduced in many settings to increase screening rates, particularly in marginalised population. And the last but very important target is that 90% of women with high-grade disease receive the treatment that they require. And even for this, we are getting point-of-care treatment options, which would allow a single visit to a health facility and screen and treat options, particularly in low and middle income settings. And before I leave this field, I do want to note that, of course, interventions for other HPV-associated cancers are being developed, but are really in their infancy. So some countries are now introducing anal cancer screening linked with treatment of precursors, starting off with people with HIV who have the highest rates of any population. Contraception, a critical element of sexual and reproductive health and rights. We have seen global fertility declines, which are really quite enormous since the 1960s, but current fertility rates remain much higher in sub-Saharan Africa and are now below replacement in some European and Asian countries. Despite those declines in global fertility rates, we still have, in some regions, a high proportion of women of reproductive age who have unmet contraceptive needs. So on the graph there, you see that in the darker colours, that in some African countries, more than 1 in 5 women of reproductive age have unmet reproductive needs. In low and middle income countries, we're still seeing that half of all pregnancies are unintended, and when pregnancy is unintended, a high rate end in abortion, which particularly in low-income settings, is often unsafe, leading to great harm. And then lastly in this field, we have seen biomedical advances with the use of long-acting reversible methods of contraceptions, but these forms of contraception, which are associated with the lowest rate of unintended pregnancies, remain underutilised. Gender-based violence was recommended in the Sustainable Development Goals of the UN to require elimination by 2030 with that elimination target. You'll see in this global map we have a long way to go. The map reporting the lifetime prevalence of ever partnered women and girls reporting physical or sexual violence by an intimate partner. Globally, that's almost 1/3 of women. So we have a very long way to go. There has been some progress in interventions, and this is guided by a framework of the United Nations called the Respect Framework, but despite that, we have not seen substantial changes in prevalence yet. Safe abortion care is critical when we are seeing that globally about 1/3 of pregnancies end in induced abortion. It is important to note that since 2020, access has been expanded in some countries, and sometimes that message is drowned out by the fact that the US has been a huge exception to this pattern, with the constitutional right to abortion having been removed, and abortion now being having limited availability now in parts of the United States. The map on this program shows the current status of global abortion access, ranging from the green, which is essentially abortion available on request, although the gestational limits will vary, to in the yellow and red, increasingly restricted availability of abortion. Of course, it's known that legal restrictions do not reduce the rate of abortions, but it's very clear they increase unsafe informal options. So abortions in the least safe conditions occur much more commonly in countries with the more restricted laws, and they also occur more commonly in countries in lower and middle income countries. And in Africa, nearly a half of abortions are occurring in the least safe conditions. We are seeing advances, and the COVID pandemic saw the expansion of primary care options for medical abortion in particular. There are options for medical abortion which are decentralized and community-based. The WHO now recommends self-management of medical abortion until 12 weeks of gestation, but really in many places, the policy and program and legal change is lagging behind the technological advance. And even within countries, racial, ethnic and socio-economic disparities to access are persistent. Infertility is an issue which is sometimes underemphasized in these international reviews, but it is important. Nearly 1 in 5 people globally experience infertility, defined as not becoming pregnant after 12 months of regular unprotected sexual intercourse. Risk factors for infertility are increasing, such as high maternal age and body mass index. And then access to infertility services is limited. And even in countries where it does exist, there is often no financial support. The graph on the right there shows the access to assisted reproductive technology cycles in the WHO regions. You will see that while access has risen over the last 2 decades, so more than just the period shown on this slide, global access remains to be very inequitable, with very little access in the African and Eastern Mediterranean regions. And public health advances in infertility prevention have been few. And the last of these areas I want to touch on, but a very important one, is comprehensive sexuality education, the elements of which are outlined in the figure here. Unfortunately, much of the debate about the use of comprehensive sexuality education has been driven by religious and traditionalist sentiments rather than by evidence-based debate. And this is particularly the case in some areas which have below replacement fertility, which has led to calls for returns to what are sometimes called conservative values, such as early marriage and childbearing, traditional gender roles, and the rejection of same-sex relationships. And as I mentioned before, the changes in technology have led to access on a scale never before to information and imagery about sex, some of which is accurate and some of which is incredibly inaccurate, highlighting that we really need to work on improving people's critical media literacy so that they can sort the fact from the fiction. So in summary, then, this epidemiological overview of the context of today's presentations finds that progress has been patchy in that it varies across geography and domains of sexual and reproductive health and rights. And it's been partial in that even where progress is happening, it is not on track to meet international targets, and it is currently under threat. There are a lot of impediments to progress. Some of the most important is that we continue at the leadership level in fora such as the United Nations to have debates that are really held back by the fact that leadership of some countries reviews discussion as being controversial. The rise of populism in some settings is leading to a backlash against sexual and reproductive health and rights. As I mentioned, progress has not been far enough, and the UN Sustainable Development Goals as they relate to this field are unlikely to be met. We did have a real hope that some areas of sub-Saharan Africa were going to meet the 90% reduction in HIV target, but they're currently very much threatened by the reductions in international assistance. We have seen areas of transformative biomedical advance, which opens the possibility of impact in some areas, and we have seen some of these as I've described today. But that variation geographically and across different interventions really shows us that biomedicine alone is not enough, and that we really need adequate financing as well as policy and program response. This really applies also to these communication technologies, which has transformed the way that not only that we learn about sex, which I've mentioned, but also the way that we provide sexual and reproductive health services over the phone or online for services such as contraception and medical and abortion. And whatever advances we have for it are really currently under threat, and I'm sure that will be a topic of some discussion today. So I would like to finish by again thanking my co-authors and to thank you all. And I'm sorry I can't be there to join with you today. Thanks very much. Bye.
Just like to thank everyone that made this series possible. I think it's a very important series. And I'll be talking about contraception, which is a fundamental pillar of sexual health and reproductive health. And it's especially important for women's health, but also important for families' health and the planet health. I'll be briefly touching on these topics, the status of contraception today, the relevance of contraception to women's health, the need for innovations in contraception, advances in contraception. I'll be touching on some new approaches for addressing the needs of marginalized populations, male contraception, and MPTs. And finally, I'll be talking about a theme that keeps recurring in this session, the headwinds that we're facing in the contraception field right now. So the status of the contraception field today, we've made a lot of progress. The population growth in the 20th century was exponential. Human population increased from 1 billion to over 8 billion in the span of less than 200 years. And it was a very steep trajectory when the female pill was introduced in 1960. And that's had a big impact. The 2/3 of the countries now have stable population growth of around 2.1 or less. And currently, 879 million women use modern contraception. And the UN predicts that the world population growth is decreasing. It's expected to increase by about 2 billion by 2080, but it certainly has dropped from the steep exponential curve that we saw in the last century. Modern contraception has several positive impacts. It modulates population growth, which alleviates pressure on the environment, and it promotes healthy families, control of family spacing and size, improved maternal and fetal children's health, lower abortion rate, empowerment of women and girls, especially improved educational opportunities and socioeconomic status. Right now, there's a contraception gap. 222 million women have an unmet need for modern contraception. This is about 1/4 of the world's population, and nearly half of all pregnancies worldwide are unintended. You see this in developing countries, but also in the socioeconomically well-off countries. And 95% of unintended pregnancies occur in women that do not use modern contraception or use it infrequently or improperly. Unintended pregnancies can affect the well-being of women and their families and adversely affect health and economic outcomes. Approximately half of unintended pregnancies are aborted, and when this occurs in countries that don't have safe abortions, there's a increased risk of maternal deaths. There's a relationship between contraception and STIs. Unprotected intercourse in the contraception age has created an STI epidemic because of unprotected sex. Over 1 million curable STIs and many more viral STIs are transmitted daily. interaction between contraceptives and STIs are condoms protect against most STIs. Hormonal contraception has mixed effects. There's a positive association with chlamydia and HSV2 and a negative association with trichomonas and BV. The spermicide naloxone 9 gave us a surprise about 20 years ago. We thought that it would be a way to inhibit HIV transmission because it's a detergent in the test tube. It kills HIV, but it actually promotes HIV transmission in high-risk groups because it causes vaginal irritation. Popular, and they would provide protection against unprotected pregnancy and STIs. So contraception for marginalized groups. Adolescent girls need inexpensive, on-demand, discreet contraception. There are two advances that are directed for this population. There are new over-the-counter oral contraceptives. One example is the O pill in this country. It's a progesterone-only pill, and it's available over-the-counter. There's also a new topical contraceptive, a vaginal cream called Phexxi, which is a low pH gel, and it's available for contraception, and it's also over-the-counter. Trans populations need more attention. Many healthcare professionals don't really know how to advise contraception for these populations. Transmasculine individuals that have not undergone gender-affirming surgery are at risk for pregnancy. These are women that now are men. And the testosterone therapy that they take does not guarantee protection. The recommendation is to use hormonal contraception and barriers or IUDs. Trans-feminine individuals that have not undergone gender-affirming surgery should use barrier methods or vasectomy. Male contraception. This is one of my favorite topics because I think that men need to do more in the contraceptive field. They share responsibility for 100% of unintended pregnancies, but they comprise less than 25% of contraceptive users. It's not totally their fault. They have limited options. Only condoms and vasectomy are modern contraceptives for men. But there's also an uptake problem. Vasectomy and tubal ligation are both surgical procedures that have about an equal minimal risk, and only 2% of men in the world have been vasectomized, whereas 27% of women have had tubal ligation. So there's a big imbalance there. And then there's a trust issue. If the method that the man's using is discreet, will women trust their partners? Will women trust their partners to take responsibility for contraception? Actually, this field is exciting right now because there are some next-generation male contraceptives that are in clinical trials. One is a hormonal birth control pill called Ness plus Tess. It's a progestin plus testosterone. It's given as a gel on the back, rubbed on the back every day, and it's currently in phase 2 clinical trials. And this hormonal birth control pill stops spermatogenesis. There are drugs that reversibly inhibit sperm production and function. YC529, which is a retinoic acid receptor antagonist, is in phase 1 trials, and it blocks spermatogenesis. And then the field's favorite candidate is a soluble adenyl cyclase inhibitor. Adenyl cyclase is an enzyme that's needed for sperm motility, and animal studies show that if you give injections of the adenyl cyclase inhibitor, the sperm stop their motility for about 24 hours, and then it rebounds. So it's a really cool potential reversible male contraceptive. And their MPTs have been slow to develop, but there are some on the horizon now. There are MPTs that combine antiretrovirals with hormonal contraception. And the one that's furthest along is the dual prevention pill, which you heard about earlier. It combines tenofovir with hormonal contraception. There are other innovative MPTs in development. One is a zinc copper Griffithson vaginal insert being developed by the Rockefeller Foundation. And then there are monoclonal antibody films that my lab's working on that combine anti-STI antibodies with anti-sperm antibodies, and they might be available in the future for MPT protection. So the headwinds, as everyone knows, the current U.S. administration is pro-natalist. They believe that population growth is good for the economy and innovation, and women should have a more traditional role. There are dramatic cuts in funding for programs that provide contraception to lower income populations, such as USAID, Title X, and Medicaid. HIV and STI programs are also affected. There have been dramatic cuts in funding to the National Science Foundation, NIH, and CDC for reproduction research. Bans on contraception education exist because people are advocating that they have pornographic content. And of course, contraception education is a pillar to contraception. The fetal personhood movement, which says that a person exists as soon as the egg is fertilized, and maybe even before, is spreading misinformation that contraceptives cause abortion, which is hindering the field. And I'd like to end with an excerpt from a speech from a hero of mine, Charlie Chaplin. He gave this speech in a movie in 1940 called The Great Dictator that was a statement against fascism at the time. And I think it actually applies for today as well. You have the love of humanity in your heart. Make this life a wonderful adventure. Let us fight for a decent world, a world of reason, where science and progress will lead to all men's and women's happiness.
Thank you, Deborah. That was wonderful. And we're moving to a next medium. So we're hopefully able to get our colleague, Dr. Remco Peters, in Geneva online to present. We'll bring that right. Great. Remco, if you want to take it away, we have Dr. Remco Peters from the World Health Organization. He's a senior project officer there, and he and Dr. Linda-Gail Bekker have developed a paper on innovations in biomedical prevention, diagnosis, and service delivery of HIV and STI.
Colleagues, thank you for inviting me to give this talk. A big thanks to Prof. Linda-Gail Bekker and Prof. Kenneth Mayer for organizing this exciting series, and big thanks to the Lancet team for putting together this exciting series, I think, which is very timely. So for the next 15 minutes, I'm going to talk about chapter 3 of this series, which is about innovations in the biomedical prevention, diagnosis, and service delivery of HIV and STIs. And this work was done with a large group of co-authors from all around the world, which I'll acknowledge in the final slide. So we've heard several speakers this morning mention that STI epidemics are interconnected, and this applies to various levels. So there's overlapping burdens both in prevalence and incidence, but there's also biological interaction and clinical interaction. So for example, untreated genital ulcers increase the risk of HIV transmission. Look at these infections in isolation, and it's really important that we generate comprehensive approaches that address both diseases. Having said that, when we look at the global health response, which has ambitious goals towards ending HIVs and STIs by 2030, the response is off track, particularly for STIs, where we see increasing trends rather than decreasing trends at the moment. So a lot of work has to be done to try and catch up in our global response. And as several of the speakers already mentioned this morning, we are facing important challenges in our funding landscape and in our global health architecture. And that means that looking at innovation is an important approach to see if we can close some of these gaps and regain some momentum that may be lost. I think it's important to say that the HIV response, as we all know, has really evolved over the last 20, 30 years, with major gains made, lots of interventions that were developed and successfully implemented. But the STI response has fallen off over the past 2 decades. So there's been very little new interventions that have emerged to address STIs. And I think it's actually an exciting time because for the first time in 10, 20 years, we have some new important innovations in STIs that are emerging and can really make an impact on the epidemic.
Camera on.
I think we're looking at doing more with less and doing it well in the changing global health landscape. And innovations can help addressing and mitigating some of these fallouts, partly to support maintenance of programs despite changes in available resources. But innovations can also accelerate access to care and increase equity, as well as promote efficiency and reduce costs, which is really important to maintain the level of care and actually expand on what we're currently doing. So altogether, innovations, I think, are really crucial, probably more crucial now than ever, to maintain the momentum that we've got in the global response and actually accelerate and scale up towards the ambitious goal of ending HIV and STIs by 2030. So I'm going to talk in the next couple of slides to some of the domains. I'm going to start with HIV prevention. I'm going to go through some of the prevention innovations. And then move to diagnosis and treatment, and then for service delivery. And there's a lot of innovations happening when you take a look at the paper that was published. There's a lot more in there. But I'm going to highlight some of the main innovations that we have seen and everything the field is going. So in the HIV prevention space, and Linda-Gail also highlighted this earlier, it's really the importance of choice that is crucial. It's not certainly not a one-size-fits-all model. The importance of choice and giving people a choice will really help scale up our prevention programs. So we have the daily oral PrEP, which actually has reasonably high efficacy, good efficacy, daily oral PrEP. But we know it works if you take it. If you don't take it, it doesn't work. It's key to effectiveness, and this is, I think, we all know one of the limitations in the real health impacts. But I don't think we should discard necessarily daily oral PrEP as an option. It's still an option that some people might prefer, and the innovation here really sits in developing service delivery models and access models that focus on preference and choice. So for some people, this option might work. I think incredibly exciting and game-changing has been the development of long-acting PrEP in recent years, and the success of lenacapavir and cabotegravir as well in the past couple of years. And these longer-acting prevention options really have the ability to transform and revolutionize our prevention fields. We know these work; they work incredibly well in prevention of HIV, and we've seen a very rapid global interest and response embracing long-acting options. And so the WHO has issued recommendations for these as part of the HIV prevention toolkit. And we see a lot of discussions on program implementation and scale up. So the innovation here, I think, will be really a focus on service delivery models in the next couple of years. How do we create models where people can access long-acting PrEP in a very easy, accessible manner? And how do we create the workforce to deliver on these inventions? And on the biomedical side, longer-acting formulations, for example, really might also be developed further. Then we've got several other options. The WVU ring, most of you know, has a somewhat lower efficacy than the other two options, but it's female-controlled and might be preferable to certain women. So again, it's an option to the toolkit and an option that some women might choose. I think an exciting other development is really development of once monthly oral tablets. Of which the trials started earlier this year, and we've heard from Deborah about multi-purpose prevention technology. So I think altogether in recent years, the menu has really expanded dramatically, offering people choice of HIV prevention technology. And having said that, I think we should really remember that both condoms for the medical circumcision and sense positive messaging are other important prevention tools, and we see in the condom space some very nice developments as well at the moment, trying to revive condom programs. On the STI side, I think it's been really exciting, and doxycycline PrEP has been an intervention that has emerged in recent years, and this means taking doxycycline within 72 hours after condom is sex. Preferably within 24 hours. And the field has been really excited about this intervention because for the first time in 20 years, we've got a new option in STI prevention. So really an opportunity to change some of the prevention space and increase the impact of prevention. So doxycycline PrEP has a efficacy for STI prevention. 70 to 80% protection against chlamydia and syphilis, and its impact varies on gonorrhea, depending on the level of resistance that gonorrhea has in certain parts of the world. Now, there are a lot of concerns about antimicrobial resistance risk. So that's the balancing act. On one hand, we've got a STI prevention that works incredibly well for syphilis and chlamydia, has some effectiveness for gonorrhea. And we see in program data that it really has a strong impact on reducing STIs within sexual health programs. This is balanced with the largely theoretical risk on antimicrobial resistance impact of using an antibiotic as prevention. So there's some data that show an increase in antimicrobial resistance and tetracycline resistance in gonorrhea, as well as tetracycline resistance in Staph aureus. But these data are not conclusive and still relatively small-scale data. So at the moment, in most settings, the STI prevention impact is favored over the antimicrobial risk. And we see increasingly programs adapting doxycycline PrEP for STI prevention for heterosexual men and transgender women. It's important to say that the one trial that was conducted in Kenya looking at the efficacy of doxycycline for STI prevention in women did not show results. So unfortunately, we're still looking at opportunities to increase STI prevention in women. And one of the options here would be intermittent use, so weekly use of doxycycline to prevent STIs in women. And the trial has recently started. So a lot more to learn on doxycycline PrEP in women. While in heterosexual men and transgender women, the main interest is on the path to the PrEP continuum and implementation considerations. So as we saw in the past with HIV, where PrEP pivoted into PrEP, the question is whether the same will happen with doxycycline. So there's several studies in the trial on the way now to understand the path to PrEP continuum for doxycycline prophylaxis. On the vaccine side, ultimately we really need a vaccine to bring down and reduce the burden of HIV and STIs. I think we're still in very early days. On the HIV side, we know important lessons have been learned from people with HIV cure. But unfortunately, the trials conducted to date have not really provided us with an effective vaccine. And it means a lot of work is to be done still in this space before we get to where we want to be. But there's some good news there as well. We've seen some promising results of broadly neutralizing antibodies in early trials. Using these for passive immunization. And there's some new approaches to vaccine development using mRNA technology as well. And I think where we still have a long road to go. I think a lot of thought at the moment goes into how we could be innovative in our way, buying vaccine candidates and evaluating these. So rather than looking at the way we've always done this, looking at innovative designs, innovative trial designs to try and facilitate evaluation and bring down the cost so that potentially successful candidates can be identified a bit earlier. On the STI side, we do have successes with the HPV and Mpox vaccines that have been successful in reducing the burden of disease. But other than those, we are really struggling. So most vaccines and vaccine candidates for STIs are in the very early stages of development. But we do have an exciting development in prevention of gonorrhea with the cross protection that's been observed for the 4C-MeB vaccine against Neisseria gonorrhea. So in several observational studies, there was a 30 to 40% reduction in gonorrhea in those with 4C-MeB vaccination. And this has been shown in real-world program data as well from Australia. So several trials are underway. The results are all expected in 2026. So it will be very interesting to see how well this vaccine protects against gonorrhea and whether it has a role in STI prevention. The UK has done their review, and based on the observational data, have decided to implement vaccination in a very specific core group of high risk, predominantly men who have sex with men, based on their data that it could avert a large number of gonorrhea infections. The other vaccines that are a bit further advanced, there's both the preventive and the therapeutic herpes simplex vaccines currently finishing phase 2 trials. And we hope that some of these results are positive and taken forward into phase 3 and further. And the original chlamydia vaccine that was developed a number of years ago by the Statens Institute in Denmark is also planning a phase 2 trial now. So early phases, but there's still movement there. As well as Sanofi, who has recently announced to test or evaluate the chlamydia vaccine in phase 1-2 trials. And unfortunately for us, syphilis, which really is an important STI, we are still far away from vaccine with only in the preclinical stage. Moving from vaccines to diagnostics, the impact of diagnostic testing in most countries has to be really looked at because most lower middle income countries rely on syndromic management, leaving asymptomatic STIs untreated. So impact of diagnostic testing is twofold. One is to reduce the burden of adverse health outcomes. And the second is to prevent onward transmission. And this relates to HIV and its positive impact on life expectancy as well as STIs to avoid reproductive tract complications and adverse birth outcomes such as congenital syphilis. So we know diagnostic screening for syphilis, for example, in pregnancy is cost effective and has a really dramatic impact on reducing congenital syphilis. When we think of large-scale implementation, there's been some really important advances in low-cost point-of-care technology. Some of these tests are available. So, for example, there is rapid tests available for chlamydia and gonorrhea detection. But these are not necessarily affordable in low and middle-income countries. So at the moment, there's quite a pipeline to push for low-cost point-of-care technology for STIs that can be used at scale in low and middle-income countries. And there's a focus on multiplex testing, so meaning a combination of multiple pathogens, such as HIV and syphilis, the dual test, as well as multi-disease platforms. So these are platforms that can where testing for various infections can be done. I mentioned the importance of affordability already. there's quite a pipeline there, and hopefully within the next 2 or 3 years, we will have a number of low-cost STI point-of-care tests that can be used both to optimize syndromic management as well as for screening. The other niche where there's a lot of interest is on self-testing and self-care as a major emerging market. We are very well aware of the HIV self-testing space. But recently, syphilis self-tests also received FDA clearance, and trying to figure out how we use this test, how it can best be used, and how we can incorporate these into existing service delivery platforms is, I think, an important next step. Having said that, quality assurance is really crucial. There's a lot of tests out there that don't necessarily meet the quality assurance standards that one would like to see. And this is an important risk of undermining trust of diagnostic testing in general and point-of-care testing in particular. So investing in development of these tests is crucial, but we should also remember quality assurance and quality assurance programs to make sure that we sustain this innovation. There's a number of important diagnostic gaps that need to be closed. So we are still looking for a test for active syphilis, both one that can be used to diagnose syphilis in people with genital ulcer disease, as well as one that can distinguish between active and previous infections. So we still have a lot of challenge if someone has had syphilis before to diagnose a reinfection or a repeat infection. And a test that can distinguish between active and previous would be very helpful. A conclusive test for congenital syphilis would be really needed, and there's some good developments in that space as well. And last of all, point-of-care test for Neisseria antimicrobial resistance. As Andrew mentioned, there's a lot of concern about rising rates of antimicrobial resistance, in particular to the cephalosporins. So a point-of-care test that combines the detection of gonorrhea with cephalosporin resistance or susceptibility profile would be very, very welcome. And again, there's some really good developments in that space. I'm going to be very brief about treatment because we didn't write much of that in the paper. Just to say that there's, in the HIV space, there's really a focus at the moment on long-acting therapies as well as simplified treatment regimens. So ways to reduce healthcare visits and make the regimens simpler, as well as, in particular, in pediatrics, options for chewable and dissolvable tablets. And another option that is not here on the list is looking at implants. On the STI side, again, it's exciting times for STIs. We've got new drugs at the moment in the pipeline for gonorrhea. So 2 new class drugs, gepotidacin and zoliflodacin, successfully completed phase 3 non-inferiority trials that were reported last year. And we're really looking forward to see how these drugs are going to make it hopefully into guidelines and programs down the line. And several other compounds are in the preclinical phases. So on the gonorrhea side, we are actually quite happy to see a pipeline of new drugs. Same on the syphilis side. We've been long reliant on BPG as syphilis treatment. But there's a lot of issues globally with access and availability of BPG for treatment of syphilis. And this provides a challenge in particular in pregnancy. So it's really good to see movement in this space, both clinical trials in non-pregnant people as well as pregnant people of Cefixime and linezolid a bit further down the line as well. So novel options emerging as well for syphilis treatment. The other options people are looking at is alternative administration of BPG. So, for example, subcutaneous of administration. And oral alternatives to IV penicillin for exposed and symptomatic newborns. So also the therapeutic pipeline for STIs is actually moving after a long drought. My last slide is about service delivery. And I think Linda-Gail gave a tremendous overview of the various service delivery approaches that are being taken both at the facility level as well as community and home-based. And we will see an increasing shift from facility to community to home-based service models and testing. But these bring their own challenges because it's not only about testing, it's also about treatment and access to treatment. And this means we need to think about task shifting, and we need to think about how people can access the full cascade of care and not only just elements. There will be an increase in innovations in telehealth, mHealth, and other digital platforms for service delivery, and we see these develop very quickly at the moment. But this does bring a strong need to think about the ethics and confidentiality of some of these platforms, but they will evolve in the coming years. Service delivery and differentiated care models will receive strong support, I think, from artificial intelligence tools and applications. And there's a variety of those out there. Some look at risk stratification algorithms, which help bring the appropriate people to care or treatment. But there's also chatbots out there that can be used for counseling or any questions around sexual health and symptoms. And we need more research in this space, but it's a rapidly expanding field, and I think we'll see a lot more of that. And then these are used for clinical applications as well. So there is artificial intelligence tools that support the diagnosis of genital ulcer and skin lesions, for example, as well as the reading of rapid test results. So this table is a summary of some of the highlights that I mentioned, and it's a bit of an optimistic summary, but I think that's fine. I think it's exciting times because we see quite a few new interventions and new innovations that will be available in the short term, such as doxycycline PEP and novel drugs for gonorrhea, as well as a rapidly expansion of AI tools to support service delivery. In the medium term, we will see a focus, I think, on longer-acting options and multi-purpose prevention technology for HIV, while there will be an ongoing search for vaccines in the STI space, as well as some novel treatment options for syphilis. But ultimately, we will need an effective vaccine, and hopefully it won't take 10 years to get there. I would say there's an exciting pipeline of innovations in HIV and STIs, but we are at a crucial point of time. It's really great to see the field, in particular the STI field, in movement for the first time in decades. And at the same time, we realize there's strong pressure at the moment through changes in global health landscape and financing. So hopefully some of these interventions can be sustained and scaled up. The novel prevention and diagnostic options that I mentioned can really revolutionize the field in the short term. I think we see differentiated care and service delivery models rapidly evolve, supported by artificial intelligence tools in the short term. And in the long term, we do need a vaccine. There is some good progress made, but we may need a bit more time to see this come to life. And with that, I would really like to thank a very strong team of co-authors. It's such a blessing to work with such an enthusiastic team. And thank you to Ken, Linda-Gail, and the Lancet team for giving us this opportunity. Thank you very much.
Thank you so much, Remco. And we're going to be transitioning again as part of our international coterie experts working on this special series. We're going to be pivoting to colleagues in South Africa. So we're very fortunate to have with us today Professor Kenneth Mayer and Lisa Jameson. They work at the Health Economics and Epidemiology Research Office at the University of Witwatersrand and also are affiliated with Boston University. And they will be talking about cost issues, who pays and what pays off. So I'll take it away, and thank you for participating.
Thank you. Thank you so much, Ken. thanks a lot for the editors and organizers of this series to invite us both to contribute to the series, but also to be able to talk to you today. Our paper, as mentioned, contributes the economic angle to the series by summarizing who pays and what pays off in sexual and reproductive health, which is, of course, a question, as we've heard throughout the presentations today, that has become more pertinent this year with large reductions in funding for sexual and reproductive health interventions. Next.
I think you can advance. You want to try?
Okay, perfect. Oh, okay, perfect. Thank you. So we are presenting this work on behalf of 16 co-authors working in 5 countries across the world, representing institutions such as the Guttmacher Institute, AVEC, Fenway Health, WHO, and a number of academic institutions. This includes 4 co-authors who unfortunately had to recuse themselves from authorship on this paper due to Mexico City policy concerns. Our paper includes HIV, STI, contraception, and abortion care, but it excludes maternal and newborn health interventions beyond HIV treatment for the elimination of vertical transmission. It is structured to first summarize the current and future funding landscapes. Given the reductions in available funding most recently, we then summarize the results of a rapid literature review that we did on the cost and cost effectiveness of interventions, including the main cost drivers and factors improving cost effectiveness. And then based on this review, we formulate a number of recommendations for future policy programs and how to build markets in this reduced funding landscape. Available funding for sexual and reproductive health and rights is not very well tracked globally, with the exception of HIV spending. But we were able to combine different data sources to look at this funding in 2023, so before the big defunding through the withdrawal of US government funding. At that stage, about 52 billion were needed every year for sexual and reproductive health and rights interventions in low and middle income countries, but only 2/3 of those, so about $35 billion were available. And so again, there was a gap of 69% in HIV, which was small, and then the gap in STIs, 54%, as well as contraception, where 60% of the funding was available. In abortion, you see that the funding needed is smaller, but that is assuming that safe abortion can be provided, which would reduce the cost or the budgets needed for abortion care by about 1/3, while of course also saving a lot of lives lost in pregnant people. This landscape, underfunded as it was by 2023, has since changed dramatically. And we are in our paper summarizing a number of modeled analyses about the impact of these cuts across the world. Across different analyses, uncertainties persist, of course, regarding the nature, size, and duration of the impact of the USAID defunding in particular, and any replacements. And as we know, all of this is currently still in flux. But we found that depending on disease areas and countries included, USAID defunding could result by 2030 in 1 to 4 million additional AIDS deaths and 4 to 11 million new HIV infections, 40 to 55 million unplanned pregnancies, and 12 to 16 million unsafe abortions. And it could reverse decades of progress towards ending AIDS. In this analysis by Ten Brink and colleagues from earlier this year, we see that across all 56 included low and middle income countries, by 2030, which is about where that blue line is now, up to 25 years of progress in ending AIDS could have been lost, taking us back to the year 2005 when it comes to AIDS deaths, and to 2010 when it comes to HIV infections. And a number of us on this call and in the room will remember how both those years felt when it came to the impact of HIV.
So under the current funding situation which we find ourselves in, doing more with what we have is crucial, while also fighting to reverse one this loss of funding, we conducted a rapid review of the literature for cost and cost effectiveness studies of HIV and STI screening interventions, as well as interventions for prevention and treatment. And we screened over 5,000 peer review papers, doing a full review of approximately 427 papers, of which 141 were included in our rapid review. And then to this, we added results from a recent review of additional sexual and reproductive health rights interventions. We extracted data on the interventions included, the relevant country or countries and settings, and the main results, including the cost and incremental cost effectiveness ratios and relevant thresholds. These are available in an extensive appendix organized by intervention area in our paper. We also extracted information on the main cost drivers across interventions, as well as factors for improving cost effectiveness. Among the cost drivers or factors contributing the most to intervention costs are, across interventions, staff costs, drug and lab monitoring costs, supplies, and outreach activities. Factors improving cost effectiveness included, across intervention areas, anything that allowed interventions to be rolled out to more people, including increasing eligibility, coverage and demand, including through community provision, and improving retention and care and earlier care initiation. On the other hand, integrated programming had the potential to reduce combined cost of interventions. So let's look a bit closer at the economic case for integrated service delivery in more detail. If the overlap between resources for, say, intervention A and intervention B is large, then providing these two interventions together will save on the shared costs. And the total cost of the integrated provision will be lower than the sum of the cost of intervention A and B. If there are no shared resources, the cost of the integrated services could, however, be the same as before, or even higher if additional resources are required. And this has been borne out in several reviews of the cost impact of integration. So in short, integration does not automatically reduce the cost of services. It can be cost saving if many resources are shared and the service being integrated into is well funded. In the case of integration of sexual reproductive health services into standing primary healthcare services in low and middle income countries, that is not unfortunately the case. If these PHC services are already underfunded, integration will not be a solution. We found a number of services where integration, in fact, save costs, including integrating HIV care into general, maternal, and child health in Kenya, integrating HIV testing, including self-testing, with other health services in many different countries, and combining rapid testing for HIV and syphilis in antenatal care. The integration of HIV and other SRH services was generally found to be more expensive, but also generated better outcomes. In other words, it was actually cost effective.
So based on what we learned from the literature and what are our recommendations, let's first look at the recommendations that we compiled in the team for policy and for regulation. Firstly, we found that we have to work together to close important gaps in financing and policy, especially for critical services such as safe abortion care. And despite the political headwinds that we've been hearing about a number of times today already. And that means that we also have to particularly work to create policy for access for marginalized populations, which the world around includes adolescents and other key populations. Secondly, given the very promising product pipeline that we've heard about today, it is central that we shorten the timelines to regulatory approval, also by, thirdly, coordinating these approval processes regionally as soon as trial results are finalized, with all other processes being queued up to take place as soon as that approval has been received. And especially for those of us who work on health planning or with health planners, that means that all the health technology assessment, budgeting, tendering, guideline development, supply chain management processes need to be prepared alongside the approval processes so they can be actioned immediately after approval. Here's a prime example of how approval timelines can be shortened, in fact. And this is where the Medicines Control Authority of Zimbabwe managed to approve cabotegravir, a new injectable HIV prevention drug, in a record 159 days after submission, and 3 months before the EU counterpart, by using an abridged review based on its existing FDA approval. And this is something that we have been using extensively now for lenacapavir approvals across the region. Then what are our recommendations, not for policy, but for programming and implementation? As we have seen, delivery outside of facilities, including through mobile outreach and community pharmacies, might be more expensive, but it will improve health outcomes and hence cost effectiveness. Importantly, we need to focus on building prevention systems, not just on single interventions, especially given the size of the pipeline for these interventions. This allows us to offer baskets of services and allows for clients to switch between products according to their needs, their preferences, and their risk profile. We also need to foster user engagement in self-care. And this is a bit of a double-edged sword. We know that it allows for further decentralization and democratization of health, but on the other hand, it may reduce some of the costs, including transport costs for the end user, but it could also increase some of the costs, including of the supplies that the end user now has to basically pay for out of pocket, or just simple issues like internet connectivity to use some of the services. The technologies that are available for self-care, and we heard a couple of them today already, are HIV self-testing, STI self-swabbing, self-injectable contraceptives, and it goes all the way to self-managed abortion. We also need to create demand, not again for a single intervention, but for the whole pipeline overall, essentially for a whole buffet of options, in particular in HIV prevention and contraception. And then finally, we need to integrate programs, if not in order to save money or not only, but in order to make it easier for clients to access all services they require in one place, thus increasing demand and enabling people to remain in care. Our final recommendations are about market shaping. So really pulling all of this together and talking about how do we create these markets fast enough to see the big benefits that we've seen and the cost effectiveness that, as we've said, almost always hinges on large volumes. So we crystallized a couple of our recommendations for how to shape these markets for individual interventions. For STI services, demand outstrips production by far, and shortages of antimicrobials are increasing worldwide. The large-scale manufacturing of these drugs offers potential for economies of scale, which would then reduce costs, while targeting interventions alleviate short-term production constraints. Targeting really is a midterm or short-term intervention. Targeting makes things often more cost-effective, but it does yield increased returns only for a limited period of time. Other solutions include onshoring production, in particular to low and middle-income countries where the need is the highest, and voluntary licensing agreements, in particular for STI diagnostics, and I would say also for HIV prevention interventions. When it comes to shaping markets for contraception, the United Nations Population Fund has recently launched a supplies partnership where domestic contributions are matched 2-to-1 to enable quality assured commodity procurement. So far, 44 countries have signed on, and 15 countries have contributed at a level that allowed them to unlock $10.5 million in contributions. When it comes to HIV prevention services, I think these provide examples for both on how to shape markets and how to absolutely not shape markets. For injectable cabotegravir for HIV prevention, WHO guidelines and regulatory approvals were far quicker than for oral PrEP, and that's this little arrow here. So the pipeline was ready, products were ready, approvals were gained within very short periods of time. as we've seen from the example from Zimbabwe. But then the rollout itself has been stymied, as we all know, by limited supplies from the originator company VIV, by delays in voluntary licenses, and by a focus on small-scale implementation studies to the detriment of large-scale rollout. And I would imagine a number of people in the room, including us, in fact, are partly guilty of having worked on those implementation studies and potentially been in the way of larger rollout. This means that 5 years after the trials ended, there's still no generic access in low and middle income countries to cabotegravir, where the drug arguably is needed the most. The rollout now of lenacapavir, even more effective injectable PrEP option, demands even greater speed, scale, and equity in planning for its introduction. And right now, it looks as if generic access could be available within 3 years after the trial, and that would be next year. Building large enough markets quickly requires strategic actions coordinated amongst all stakeholders. We can, at this stage, ill afford to be pitted against each other in the scramble to bring limited resources to bear for those who need them most. So in summary, our review and our recommendations showed that sexual and reproductive health and rights interventions are among the most cost-effective health interventions the world has seen, with large returns for society overall, but their funding is under severe duress. These interventions rely heavily on donor funding, which has decreased since 2017. In 2023, as we've seen, we had about 2/3 of the funds needed available. And that has since decreased. As we've seen, the USAID funding in particular could result in the next 5 years in 1 to 4 million additional AIDS deaths and 4 to 11 million new HIV infections, and in millions of unplanned pregnancies and unsafe abortions, and a reversal of the progress towards ending AIDS. In this situation of decreased funding, programming that improves cost effectiveness is crucial, for which scale and speed are central, both things for which we have to spend more first to spend less later. We have to, in order to achieve that, unlock demand for the supplies, for the services and products through novel funding, and by working together to build exactly that, those flexible demand and shorten time to market for novel products. We acknowledge the support from the Gates Foundation for this publication and the entire series, and we hope that we've sparked some interest in the economics of this aspect in particular, and for the entire series. Thanks a lot.
Okay, thank you very much. Well, good afternoon, everyone. It's almost afternoon at this point. So on behalf of a team... Will echo? Should I wait?
Something that we so they say or questions.
Okay to proceed? Great. So on behalf of a team of colleagues from 4 continents, I really consider this the A-team. We spent some time talking about the challenges and opportunities in developing integrated sexual and reproductive health programs globally. So, we've heard the theme today that we so much think of these things in the past as silos, and they're so inextricably interwoven, it's really hard to disentangle. And the goal is ultimately one-stop shopping, but that's always easier said than done. So the first issue is, what is the database that says that these issues are inextricably interwoven? So this diagram that looks like something that Frank Lloyd Wright might have designed really shows a lot of the different associations between HIV, STI, and reproductive health outcomes. If we want to unpack and deconstruct a little bit, there's some basic themes. We can talk about themes related to biology. So we know that sexually transmitted infections increase inflammation or ulceration, and that will increase the risk of HIV transmission or acquisition. Similarly, HIV will have an impact on STI on people who are not on effective therapy. So immunosuppression will increase both STI severity and infectiousness, will increase a viral load, for example, of herpes. when we treat people living with HIV, that will decrease the likelihood of transmission, U equals U. This will also decrease mother-to-child, parent-to-child transmission. And then HIV and STI have numerous adverse obstetrical outcomes. But there are also behavioral issues. At most simple level, in terms of any transmission of an STI, like HIV or other STIs, increased number of partners, increased risk of an STI. But behavior is now more complex. In an era where we have PrEP and where we have U equals U, there's more condomless sex, which means less HIV potentially being transmitted, but potentially more other STIs. And we also know that there are complex impacts of hormonal contraception, certainly at the very least, the use of barrier protection. And then there are the epidemiologic and social and cultural issues. Assortative mixing is a very important factor. So people are more likely to have sex with people from within their same peer group. This can really lead to concentration of epidemics. An example of that in the United States is the very concentrated epidemic of HIV among Black men who have sex with men in the U.S. South. Studies show that Black men who have sex with men are not having more sexual partners than middle-class white MSM and in the North, but because of the concentration of the virus. And then the other factors, lower socioeconomic status, may affect health literacy. They also affect ability to make protective decisions. And adverse political environments may decrease access to preventive services. So all these things are bundled together, and we really have to address them in a much more holistic way. But why, if we make the case that they're all together, then why have they been approached separately? Well, traditionally, family planning is focused on reproductive health, and HIV and STI in the early stages of the epidemic were associated with key populations, many of whom may not be likely to be involved in reproductive health issues. There's also geographic variability, different epidemics in different parts of the world, leading to different sexual and reproductive health needs. And this also has led to different clinicians for different populations. So there's certainly a kind of NIMBY, not in my backyard kind of attitude in the early days of some clinicians saying, those other clinicians take care of this group of patients. That's not my purview. And there are different institutional cultures. HIV grew out of a lot of community activism in the early days, where the pace of development of treatment for HIV was slower, and the creativity of groups like ACT UP really led to an activist culture. The public health approach may oftentimes be seen as very top-down, with public health officials taking decisions to make treatments available or testing available based on public health fiat. The regulation of sex workers, for example, has been traditionally very much in the public health purview of things. And then there are categorical funding streams. And certainly we cannot underestimate the incredible role that PEPFAR has played in saving lives, but certainly PEPFAR was HIV focused, and sometimes to the detriment of other important needs around sexual reproductive health in the same communities. And at this point in time, there are resource constraints, and sometimes public health officials think of it as a zero-sum game. When we talk about integration, it's also there are a lot of nuances and complexities. Integration can mean at the individual level, getting all services at one center, and the clinical facilities need to scale up to provide the one-stop shopping. But this doesn't happen in a vacuum, so we have to think about what's integration at the governmental level, public health officials, what's the integration at the level of normative bodies, what's integration at the level of provider education, cross-training of providers who don't see their role necessarily around specific aspects of sexual or reproductive health. And then in terms of the technology, we've heard from Dr. Anderson about multi-purpose technologies, and these are very exciting, but there are regulatory considerations that are important. They may provide a tool for integration, but how do we study them is going to be important. And then we obviously have to think about integration at the funder level, so that funders see the need to support all aspects of sexual and reproductive health. So in the paper, there's kind of a list of the pros and cons. I won't go through them point by point, but obviously, there are a number of levels where integration can be very beneficial. Certainly, the most important thing is at the individual patient consumer level, where the idea is that one can go to one health facility and get all their healthcare needs met. Now, with electronic technologies, with electronic medical records, patient's trajectory can be effectively tracked through integrated electronic medical records. Hopefully, there can be shared resources and better informed providers and less siloization of programming. And there may be cost efficiencies, and you heard from Drs. Mayer, Raff, and Jameson about some of those efficiencies, and we'll talk about other examples that we reviewed. And we had these novel products. There also are possible savings at the supply chain level of ordering consumables and other important products. So integration can have many benefits. But the reason why we don't have integration yesterday is because there also are challenges. People may be asked to receive care in unsuitable spaces. So if there's less funding from programs like PEPFAR, key populations may not feel comfortable going to a reproductive health clinic or vice versa. There may be national and donor-specific guidelines that don't support integration. The cross-training of providers is a challenge as well. Reporting structures may be more limited. This may create extra strain on already burdened healthcare systems. And we have to think in terms of clinical trials, how we study integrated approaches and integrated products, thinking about composite outcomes and how do you undergo regulatory approval when you're having products with different indications. And the supply chain could potentially be more complex. So it's not an easy process. So our group looked at the literature. So there have been several systematic reviews of the first one from Kennedy in 2010 found that there were some benefits from integration. Subsequent study by Haberlin from more countries looked at also uptake of several modern methods of hormonal contraception when family planning services were offered at the same facility. We looked at two studies from Kenya that also looked very promising. That women who are receiving services in HIV care clinic were more likely to access short-term contraception when they received integrated services. So interestingly, the rate of access to longer-acting contraception did not differ by the service model, but the vast majority of the women expressed satisfaction with the integrated model of care. And another study also found improved patient-provider communication and better planning for resource utilization. So all very promising. A much larger, more recent study, really the definitive study, looking at 115 studies from 15 African, 5 Asian, the 3 European countries, as well as the U.S., found uptake in a number of different parameters, things like ART initiation coverage, time to initiation, retention and care, and viral suppression were better. And treatment for non-HIV diseases, an uptake of non-HIV services was also improved. But their meta-analyses didn't show significant differences in HIV testing yield, ART adherence, or HIV survival in infants, and overall HIV and non-HIV mortality. This doesn't mean that integration doesn't work or shouldn't be considered, because a number of these other outcomes are really important, but certainly raises the question of how do we do integration better in specific contexts. And in this specific Lancet paper that we prepared, we wanted to give some case studies. So we gave 2 very different case studies that have been signal successes. One has been a program in the Zambian Ministry of Health, which has integrated family planning and HIV services and has had salutary outcomes. And the other is the Tangerine Clinic in Bangkok, which is a very community focused program focusing on the transgender community and has increased uptake of PrEP, as shown decreases in HIV and STI compared to prior to the initiation of the clinic. Sadly, both of these programs are heavily funded by PEPFAR, so their existence is very much in peril, but they are success stories that we wanted to highlight and uplift. The other thing when we talk about integration, and Dr. Bekker talked about this in her keynote. There are various ways that we can integrate. So we can co-locate services and give comprehensive care in a clinic, but we have mobile clinics. We can do school health programs. We can do pharmacy programs. We have to think at the Ministry of Health level, is this vertical integration where everything's managed by a single administrative structure, or is it cross-linking existing structures as well? And what does this mean in terms of the training of healthcare workers, the supply chain, and bringing on the non-professional members of the team to be able to facilitate the integration process. I mentioned multipurpose technology, and our colleague, Dr. Veronica Miller, led the section on the whole issue of multipurpose technologies in terms of the clinical research enterprise. There are a variety of issues that have to be considered. There are different regulatory norms of the FDA versus the European Medicines Association versus the South African and other African regulatory bodies. And we have to think about when you're having indications for a product that may protect against HIV and protect against STI or protect against STI in conception, there are different regulatory hurdles. So this is another area where we have to think about as we try to move forward on the integration agenda. In terms of investment, we heard from Drs. Meyer-Rath and Jameson about the issues. One issue of investment that we have to pay attention to is investment in research to develop these products, and then to also understand how to implement them. And the U.S. has really been the major donor, and certainly we have concern about going forward whether this will continue. Fortunately, the Gates Foundation has recently announced a $2.5 billion investment in women's health research, and that does include support of research into multipurpose technologies and integrated approaches to address HIV, STI, and other aspects of reproductive health. The European governments are also contributing funding, and certainly pharmaceutical companies have some investment in MPTs and other of these approaches. But again, we have to pay attention and be strong advocates to ensure that the resources are there to continue this work going forward. And certainly at the implementation level, it has been a very grim few months. And the trouble is that there were decreases in support for HIV and some of these other areas even before the advent of the Trump administration. So modest decreases, but still decreases in 3 years prior to the Trump administration. And this is not just the United States. There's been decreased funding in the United Kingdom, France, and Germany, which is also a concern. And donor support for family planning has also decreased as well. And then we have major concern about the Mexico City Convention, the Geneva Consensus, which basically will withdraw support from programs that are providing safe abortions or programs that are supporting sexual gender minority individuals. So these are definitely going to be challenges the years ahead, where people will need to make the evidence case that it's important to keep supporting these programs and not have an ideological agenda. These programs have to address human rights. Certainly many of the people who would benefit most from integrated approaches are among the most marginalized individuals in the world, both in terms of sexuality, gender identity, as well as economic circumstances. And certainly there are a lot of local challenges as well. Continued discrimination, criminalization of sexual behavior, and prevalence of misinformation and stigma in healthcare facilities exacerbates these issues as well. And we have to continue to advocate for evidence-based policies to promote community health. The other aspect of integration is integration doesn't mean the same package for all individuals. And Dr. Bekker talked eloquently about this previously, but we want some of the same things, but they're going to be different issues. So certainly communities where people are using drugs, we need to think about harm reduction programs. Certainly other populations, we have to really ensure that gender-based violence programs are also part of the package, that we can't just focus on the shiny bullets of the latest pill or latest injection. And so there will be differential service delivery. So there'll be integration, but it'll be different integration for different populations. There are different key stakeholders who need to be involved in ensuring access to integration. You'll hear a little more about this from Dr. Bekker momentarily when we do the call to action. So in conclusion, integration of HIV, STI, and other aspects of sexual and reproductive health, it's highly desirable. It's an opportunity for users, providers, health systems, and policymakers. And certainly it intuitively makes sense. But there are challenges. There are challenges at the patient level. There are challenges at the development of new products. The funding streams need to become more flexible. Legal environments have to become more accessible. Providers need to be adequately trained. And it's an ongoing process. So this sounds somewhat utopian, but to bring together the theme of this whole special series, the reason why we think that integration of these programs is not so utopian is that paper 1, we showed that we are living in a world where millions of incident cases of STI, HIV, and unplanned pregnancies occur each year. So we have to do better. Papers 2 and 3 describe exciting new breakthroughs that can result in even more effective approaches to address all aspects of sexual and reproductive health. And paper 4 discusses the cost effectiveness and cost savings of many of these approaches. So the time to act is now. I want to thank a grant from the Gates Foundation to allow us to be able to think together to present this work to you and our colleagues. And now I'll turn it over to Dr. Bekker to talk about our call to action. Thank you.
Everyone, just before my voice completely didn't.
These little slides.
Yes.
Yep.
And I know you've all put through a lot of you've had a lot of slides. They're just 12 together because there are 12 pieces we are calling out. Okay. Thank you. Oh my God. Yes, it is. It's my voice, that's all. Okay. All right. So, as Miriam said, when we write this series, it's really important that we call out what are the actions that do follow, so we can monitor them, evaluate them, and track them over time. And there are 12. I want to thank Miriam for helping us bring this incredible group of authors together and distill the 12 actions which Ken led us to get our heads around what they are. So, the first, and sorry, things have shifted a little bit, but the first is to think about national leadership. And so each of you need to think of where you are in the world and think about your nation, and that nation taking the lead on this, designing the long-term sustainable packages or services that need to be brought together, giving the limitations of donor support, obviously, to really think about, as has been said many times today, how do we do more with less and do it well? And then the integration needs to be embedded within health sector strategies, budgets, and monitoring frameworks, of course, hence the need for it to be nation-specific. We need to prioritize and institutionalize integration, so this has to become not a fly-by-night, flip-flopping thing. It needs to really get stuck and stay. I think we made some progress on HIV and TB. I think we're really starting to see that gel, and we want to see that happen now with SRH. So that needs normative agencies, ministries of health, international funders, all need to come together to say this is what, and I already described how UNAIDS is moving, WHO is moving, so this is all good news in that regard. Although a standardized model is neither feasible nor advised, each sector should assess how its portfolio can better support streamlined and user-centered services.
Would you give you wrong?
Oh.
Let's see if this works.
Okay. Am I waving it around?
Yeah.
Sorry. Okay. In the interest of time, healthcare worker training and task shifting is the next thing. To ensure delivery capacity of the highest standards of care to the greatest number of people, the healthcare workforce needs to be trained and equipped. So one of the biggest things I've found for healthcare providers to take on more is fear that they actually don't know what it is that they need to do. And if we can equip healthcare workers, with those streamlined standard operating procedures, algorithms, maybe assisted guidance with artificial intelligence, etc., I think we're going to see this happen far more effectively. Task shifting we've spoken about today. I think that's the way of the future. It cannot all be in the setting of medical clinicians. It's got to go broader. And I know this country has a wonderful group of nurse practitioners, and beyond that, outside of the sort of medical clinician. And we need to see those used more and more. At minimum, providers need to be trained to recognise unmet sexual and reproductive health and rights needs. So referral when they're out of their depth, and at least recognising. So many sexual minorities say they walk into a clinic and the healthcare provider they meet just doesn't have a good understanding of the kind of sex that this person may want or engage in. Person-centered, choice-driven care. If you haven't sort of heard that in various different ways today, then you've not been listening. We at the heart of this, and I think Lisa and Casina said it very nicely, it may cost more, but the effectiveness comes because we get a better result. And I think that's really terrific for us to be bearing in mind. So respect of individual preferences and a full range of sexual and reproductive health services. All of this is really important. A big one that comes and goes, right? I think paper one beautifully summed it up. The progress we've made, but we've also lost ground in some places, and it feels very raw in 2025, where it seems that ideology and policies have really backstepped. So these reforms need to regularise access to comprehensive, affordable, inclusive sexual and reproductive health services, including universal and unrestricted access to safe abortion. Somehow we have to get this message across. Contraception services for survivors of sexual and gender-based violence. These are some of my favourite protest slogans, in case you didn't notice. So we are a group of activist-minded individuals, so all is well with the world. Okay, evidence-based programs. Clearly, we can't just ask people to do these things. We have to ask them to do it because there is strong evidence base supporting it. And this includes around harmful legislation and guidelines that need to be urgently challenged and replaced. As already mentioned, policies and guidelines should be informed by decades of research results, and decrim of same-sex relationships, sex work, and drug use also need to be prioritized to uphold bodily autonomy and public health. And this is where series repeat themselves. I so remember standing and doing the call to action for the sex work paper of 2018, I think it was, or 2016, and asking it for exactly this at that time. So this is why we've got to monitor what our progress is so we move forward. We can't do this without community, and community needs resources. So supporting communities and civil society is absolutely key and critical. And as money disappears, the first group that get defunded are the community-based organizations that have led our field, led our movement, and made the difference. So there's a real call to action in this regard. Community health workers and lay providers play a key role in addressing those gaps. And, I can't tell you how we have felt that in South Africa. 15,000 people were retrenched as a result of the new administration and the loss of USAID. Most of them were not medical practitioners. They were lay healthcare workers and nurses. A tragedy. Finally, not finally, but access to innovation. I think that's been beautifully said today. We have to keep on innovating. There are gaps still, and also there will be gaps because we will get resistance to products. We will find products no longer work, and so we have to keep doing this. And you heard there's a big gap in vaccines, so this really is very important. And how we continue to fund these needs innovation in its own right, so we have to think about that. Innovation in procurement is a big one. This goes across, services, nations, international, regional areas. So there are I think, really nice pieces of work starting to come forward to say, how can we do this innovatively as well? How do we, procure in a way that makes the dollars go further? Ongoing research and development. This also is a call not only in terms of products, but also how we do things, how we fund them, how we integrate them, all of that, whether it's implementation science, clinical trial, or policy research, it needs to continue. And of course, funding for this is really important. Rights remain central to all of this. The promise of integrated sexual and reproductive health programming can only be realized when we also pay attention to rights and dignity. And this, of course, means policies dismantling stigma, ensuring sustained investment in this regard. And of course, strong affirmations, even when we hear a pushback, that we continue to hold forth in terms of what we believe. And then finally, this, which I've been hearing a lot of in the last 6 months, this need for self-reliance and diverse funding. And this is where we really do, need to see a shift, particularly in low and middle income countries, where more ownership needs to be in this regard. And this requires each of us. Miriam said it beautifully. We have to take these back to wherever we are and use this to change the paradigms. This is going to be, unfortunately, doing more with less, but also really encouraging new money in new ways to come forward, and some of that is national government. And with that, I really want to thank again the Lancet and Miriam, Ken, and this fantastic Fenway team. Thank you to the IT people. I know there's one more very important. So I'm going to just say the paper leads, the co-authors, Jen Head, and our funders. Thank you.
That was great, Linda-Gail. And we are now slide free, but, we're doing this, spending the time together today in a community setting. And I think it's really important for us to think about the community when we talk about all these very important and heady issues. I'm very happy and appreciative that my colleague Adriana Bullen, who's Fenway's Director of Racial Equity, Social Justice, and Community Engagement, will share some reflections from a community perspective. So thank you, Adriana, for being here with us today.
Hi, everyone. Hi. Waving. It's really nice to be here with you all. And I just want to thank the authors and everyone in this space. This has been such a comprehensive series. I've learned so much. I've had so many reflections. I want to start with what you actually called in, Dr. Linda-Gail Bekker. I really appreciate you mentioning Ubuntu. That is a real personal value, mantra, structure for me. The whole idea of I am because you are. And one other that I'll offer in this space is by an Indigenous Australian elder named Lila Watson, who says, if you're here to help me, you're wasting your time. But if you're here because your liberation is found in mind, then let's work together. And I think about that as we explore like this system that we're thinking together. The health of the folks we are seeking to support is also giving back to our own health, and we need to remember that. And when I think about the themes that came up for me during these papers and these presentations, it really is integration and innovation. But even further, I also appreciate that you lifted up, and others, the socio-ecological model. It's conscious awareness of integration and innovation at all those levels, the interpersonal, the organizational, the community, the policy. It's really awareness, conscious awareness of what it looks like to integrate and innovate at all those levels. So thank you for calling that in and highlighting that again here as I share some more reflections. I also really loved the train analogy. So you were just how you began was really great. And so I'm going to continue with that. And in Boston, compared to maybe some other cities around the nation and in the world, I think has like a robust transit system, bus, trains, otherwise. And so I'm calling that into what I'll share now. I want to invite you to imagine a city where every bus and train has a different map, a different schedule, and a different system of paying your fare. And in this system or city, say you have to get to your destination health station, right? And you're on your way there, and maybe you have to take a train to another bus, and a bus that doesn't take cash. And maybe you have to use the app for that. And maybe you have to walk 2 miles after you have reached this bus station to reach the other train. Sexual and reproductive health care sometimes can be that way. When services are fragmented, it can feel like there are these barriers, that there's extra energy that you have to put out there. And what I heard today and what I've read in the papers really talks about how we can integrate and innovate at the different levels so that we can reduce that. So there aren't barriers to people getting to where they need to go in terms of destination health, and where every route connects and transfers seamlessly, and where people can reach where they're going safely, efficiently, and with a sense of dignity. I also want to talk about how why integration matters so much. We've heard a lot about it here, but in short, it's accessibility, it's cost savings, it's resource savings. And I was reflecting on the earlier example given about pairing HIV prevention strategies and methods with hair braiding. And I was like, I would be there getting tested once, okay? So I loved that. I think that's so creative and innovative. And it's that type of pairing and layering that will really influence people's acceptability and engagement in different practices. And I'm thinking also about a station that we have here in the United States, Boston, Massachusetts, called Downtown Crossing. It's one of my favorite. It's always been my favorite because it's so integrated. There are 2 direct lines that are at that station, and then 2 others. So there's the red line and orange line for those that might be familiar with the Boston area. If you go above ground from that underground station, there's a silver line. And then if you walk underground, still connected to that same station, you can get to the green line. That system of integration has helped me not decide to not go to places because it's hard to get there. It's allowed me to get to appointments on time. It's allowed me to navigate in ways that have just felt powerful. I don't feel like, oh no, I have to wait here. I have to walk here and go a different place. And that was coming up for me while I was sitting here thinking about it. I also wanted to talk about drivers of acceptability and ways and mechanisms that help us recognize that we are connected. Going back to that Ubuntu, going back to the fact that all of our liberation is connected with each other. U equals U is such a great example, and I love that it was lifted up in these papers. And I also love sharing that with friends and colleagues and loved ones. They're like, what? Wait, so there's undetectable? What does that mean? Seriously? It breaks down this you're over there, I'm over here dynamic of people. It really shows we are a part of, going back to the city and the transit system, we're still in the same city of care. Yep, that's what it means. It destigmatizes that. And that's what we really need in this work, is to destigmatize the ways in which we describe things and allow people to receive it better, recognizing that difference. And I also want to mention, in thinking about that, going back to the train example, I born and raised in Boston and Kingston, Jamaica, just throwing it out there. Yeah. But going back to Boston, I also went to undergrad and grad here in Boston. And before having a vehicle and traveling to different places, if someone wanted to meet up somewhere and I could not get there by the train, I wasn't going. Or it would be like, what, you live that far, etc. But the moment a new line came in, or it was more accessible to get there, all of a sudden it's easier. It's not this desolate place over there. It's now someplace that I can see and recognize. I see the map. okay, this number of minutes it might take, or there might be a delay. Just having that level of framing and architecture around care, like U equals U, really helps the uptake of it. Now I want to talk about informed navigation. And I'm thinking about a lot about what Deborah Anderson called in around the different ways in which we understand humans, their lived needs and experiences, and how that relates to the different options that they might need. I really appreciate the learning about the multi-purpose prevention technologies. That was new language for me. I think I knew what it was, but not that language. And so thank you for offering that language. And I remember being young and growing and thinking about, it'd be so cool if this was paired with this, it would be so easy. I wouldn't have to take all these different things. And that was just, dreaming, and now it's reality. And that's what we're doing. We're constantly in this moment creating our future. And that's why coming together in these ways are so important. And I think in a world where we, as humans, live and exist at different intersections, context matters. It's been discussed a lot today, and nuance exists. We're human, and that's how the world is. And we need to understand, people need to understand the pros and cons of different methods, and to be supported depending on where they might need to go if you want to switch lines. So if you want to switch contraceptives, if you are switching between prevention and treatment of something. So the fact that that is easier really supports people and allows them to feel empowered, to be empowered, to feel their inherent power that already exists, but sometimes this world makes it hard to see. Coming close to the close, talking about some challenges to integration. I think it's really important to recognize the challenges that exist that have been mentioned: funding, restrictive policies, infrastructure that might be outdated. When you're combining new things and old things, sometimes they don't always flow well. And so thinking about how to do that creatively in this work. And I'm also thinking about the challenges related to social barriers that exist. I've noticed in the world and in the health system where processes or methods are innovated, they aren't culturally responsive, and they leave people behind. And so now people stop riding the train altogether. You've updated the train, has new seats, it announces in English only what stop you come off at. And it's like, this is going to make things better for some people. But for others, it causes distrust. Now you don't feel safe on the train. You're not sure where you're going. And so you don't take it. And so you don't take the train to destination health. So I think it's really important to think about and really be person-centered. I just want to the 12 steps here was amazing. And I so look forward to thinking about that as a framework in my own work as an activist, as a human being, and really look forward to sharing that with others. And just one thing I want to uplift too is really, I love our mayor, Mayor Michelle Wu. And so I'm offering an example here. I respect her for so many reasons. And one thing that she has done that sticks out is in terms of transportation. She has put so much work into innovating policies and systems and structures around transportation, free bus program. And what she did, she took the bus to work. She took the bus to work with other people to understand what it was like. She had conversations on the bus. How long have you been waiting for the bus? When did it say on the app that it was going to arrive? And did it actually arrive at that time? What might you need here? And so really thinking about those different aspects and also the norms that might be helpful to support people. And so something I've always noticed here in Boston is if there's someone who is in a wheelchair or needs some support in some way, it is automatic that once they approach the bus vehicle, the bus goes down, the bus driver comes out, they support the person to get in. I've never not seen it happen. In all the years that I've lived in the city, I can trust that. And so can individuals that need that support. When I have visited Dubai, what I've loved about their train system, and I look forward to this norm being applied in Boston, is there are on the floor in front of the train, there are signs to show you that if you are entering the train, you enter from the sides. And if you are exiting the train, you exit from the middle. And that prevents and when it's like peak rush hour in the morning and the afternoon, it's so just little things like that really help us as we're integrating and innovating, thinking about what the lived experiences and needs of people are. And so thank you again, all, and look forward to connecting with you more.
Thank you so much, Adriana. So we have some time for question and answers. And the most effective thing would be for the speakers to come up here. So we come to that.
I'll say what we can do is, so I have 9 questions from online. Folks did not say to this person. So I'm going to bring the questions first to see ask questions first, and then we'll bring up the questions. Ask.
Okay, you're going to put the questions on the screen. Great. Okay. Any questions here from the audience? Jay.
I'm first minister Dr. Never Ended. I was wondering if you could say a little bit more about monoclonal antibodies and where they're at in development and stuff. And monoclonal antibodies have used therapy and little acid.
We can disconnect right here. Okay, so no more.
Cells. Large numbers of stability guys that really like sure.
Thank you.
The nuclear miles now were feeding there. Developing them will follow this. Other than us, raising my levels for yeah. It's very expensive.
We're hoping that the topical approach might be more targeted and more cost-effective and more acceptable.
It's still very nascent.
Very nascent.
That's like I think.
Any other questions?
Okay.
It's still opening. Just bye.
Comments, questions.
Mary, yes, Justin.
This was fantastic. I guess I have a big question, which is, kind of given particularly the political situation in the U.S., what are the folks that were a part of this collective, what are your thoughts about really trying to translate this into our current reality, given how difficult it's going to be? So I'm just wondering if you might speak more about sort of your early thoughts about what that implementation might look like. I know that's a big question, but it's something that I'm really, really interested in just hearing what people are thinking about. So,
I think it was Benjamin Franklin said, facts are stubborn things, right? I mean, I think one thing is generating new knowledge and just trying to present it. Have to assume that not everybody is crazy in the administration, and hopefully that evidence can help influence. Certainly helping to talk to the community and trying to develop political will, I think is important. Certainly 7 million people, a lot of those 7 million people, I think, probably would support a lot of the things that we were talking about today. And hopefully those numbers may increase over time, but that's from a domestic perspective. LGB globally?
Yeah, so what I was going to say is one of my comforting, I suppose, sort of statements is in the year 2000, we faced a devastating HIV epidemic with a president who did not believe that HIV caused AIDS, and a health minister who believed that we should give out garlic, rhubarb, and African potato instead of antiretrovirals. So yes, there were other structural things like they were unaffordable, we couldn't get our hands on them, but there was this massive political sort of barrier to even moving this forward. And what we essentially did is work around the government. And so, obviously there's some things you just can't move, but there's some things where you just have to say, do it. Not say it at all, I'm just going to call it something else, go in a different direction, different resource. So we just had to get really, I suppose, stealthy about how we go about and with a strong resolve. And one thing I would get you, and I think congrats that we watched from afar this nation rise up on the King's Day. They can really swing large masses of people who normally vote and say, no, all this is not happening on our watch. And that was really our story. The team that actually campaigned in very loud first place saying, this is not okay. And they get this magic. So, this is amazing. They call out and then he said, also, I didn't read that paper. I didn't read Turkey to enough. You should read this. And he funny. At some point, he stopped impacting us to the extent that he was. Okay.
What is this?
That's it.
Okay.
Yeah, the mic battery is there here. Yeah. Great. Yeah, it's a bit chunky. But
that's okay.
Yeah.
This better? Yeah. Yeah, and Justin, there's one other piece of the equation, which is you and your colleagues. So some of us are a little long in tooth, and I think this is not something we're going to solve tomorrow. And we've been, as Linda-Gail said, we've been bad times before. So I think I'm just encouraged to see many people here who are in training and early stage of career, and you are the future. And we're all in this together. And hopefully, that was one of the intentions of this series, is to sort of synthesize what's the current state of knowledge, point directions to the future, and hopefully inspire people like yourself to be doing great work. So we look forward to watching people, the next generation's success. Put it that way. Okay. How can clinicians, advocates, community organizations translate your findings into action, everyday practice, or programming? I think we sort of covered some of that. Anybody else from the presenters make any comments about that?
Oh, I'm just here. Just one small thought on this question, and that is, you saw it, but we didn't talk about it specifically in all the papers. There are great graphics and tables and summary pieces, and those can be, I think, really used effectively, sort of translate some of what's in the paper already. It's already kind of there for you, and then you could play around with it, you could adapt it to your particular setting and use those. So it's just one thought.
Veronica, a comment? No, we need your much.
I'll hold it for you.
It's more of a comment than a question. First of all, I wanted to personally also congratulate Ken and Linda-Gail, and wonderful that you are here to celebrate this. And Miriam, you're the people I work with the closest. And echo what you just said, Miriam. The graphics are just wonderful, and I think that's one of the contributions of Lancet, and I couldn't wait for this to be published so I could actually use the graphics in some of my lectures at Berkeley. So just huge congratulations. It's such a milestone, and I know it was a real labor of love. It wasn't easy to put together, but when you look at when you hear the message, on the one hand, it's such a no-brainer. Well, of course, if they're young women, you want them to have access everything in one place and make it friendly for them. But the fact that you can so convincingly demonstrate how this works and provide roadmaps how to do it, I think in this time where we have to be so conscious of restricted funding and being more efficient all around, those are great lessons. Thank you.
Maybe you want to go to the next question? Okay. Given competing health priorities, COVID-19, climate change, economic downturns, how do SRH services maintain momentum? It's a good question. I'm just curious, are Gesine and Lisa also able to respond? Because they may...
Marco, Daryl...
They can respond. Yes. Can they respond verbally?
Yes, absolutely.
Gesine, Lisa, do either of you want to comment? Since you're thinking about...
With the question that I do think has an economic lens.
Right.
And also the health economics actually provides the answer. I mean...
Respond verbally?
I'm trying. Can someone hear me?
Yes. Lisa, do either of you want to comment?
Yes, I would love to. Can you hear me? Yeah, and that's actually a question that I don't think has an economic lens.
Right.
And also the health economics actually provides the answer. I mean,
respond verbally?
Yeah, I'll try. Can you hear me?
Yes.
Can you hear me now?
Lisa, do either of you want to comment?
Yes, I would love to. Can you hear me? Okay, so oddly, I was just talking over myself, which is really an experience I haven't had in my life. But let me try again. So this is exactly the kind of question that health economics tries to answer, where we compare basically the cost and the impact of different interventions using the same metrics, and especially across different health priorities, that actually works quite well. So earlier I was just talking over myself, which is really an experience I haven't had in my life. But let me try again. So this is exactly the kind of question that health economics of different interventions using the same metrics, and especially across different health priorities, that actually works quite well. I was just talking about myself, which is really an experience I haven't had in my life. But let me try again. I don't know. I can't hear them.
Yes. Yeah.
Okay, so if I can go again very quickly, we can look at the incremental cost effectiveness, or even the cost benefit, which is a slightly different metric of different health interventions. And we've done so. So we've compared interventions against COVID. There's a possibility to look at climate change interventions. And all of this brings up a set of metrics that allows you to actually compare where you should spend your money first, both across different health interventions, but also even wider than that. And in our review of incremental cost effectiveness ratios for SRH interventions, we found that they had exceptionally high, not only cost effectiveness, but also cost benefit, where we basically then look at the economic impact across all of society of providing these interventions. SRH interventions are, as we said, amongst the most cost-effective the world has seen, and they have exceptionally high cost-benefit ratios, often in the region of, for every dollar spent, you get $13, sometimes $20 back, mostly because keeping people healthy and longer across the world has a high economic return. And so those are metrics that you can use to make that case and to make the economic case for spending more money on SRH than other interventions. Thanks.
We'll go to the next question. Very little impacts, very high restoration for all services. And you share a successful case example.
I think if you look at the paper, there are two good examples. One is from the Zambian Ministry of Health, and the other is from the Tangerine Clinic in Bangkok. Very different populations. The Zambian example is focusing on women of reproductive age and trying to integrate care around family planning, HIV and STI. Tangerine Clinic focuses transgender community, a very community-informed, community-engaged model, and they both are really great examples. I don't know if anyone else would like to give an example. This another question?
Yeah.
Sure. Let me hold it for you. It's a little complicated. Yeah, it falls apart.
Hi, can you hear me? Yeah, so we've been talking a lot about integrated services. Specifically, a couple of examples have been integrative services in regard to injection substance use and also transgender health. Given the context that the federal government is prohibiting transgender health services for persons under the age of 19, and many clinics have stopped their provision of these resources, as well as prohibiting safe needle exchange and safe injection sites through federal orders. What is the plan for engaging these communities? When you take away these services, how will these communities continue to be engaged in care? So that's my question. Yeah.
Yeah, it's a very important question. I don't think there's one easy, simple answer, but I think that integration is the goal, and sometimes these federal policies make integration very difficult. So the most important thing is to ensure that people get access to the services, which certainly there are case examples of that where using non-federal funds. So I think one of the problems, certainly in the United States, is that a lot of the programs that we look to provide the integrated services are very reliant on federal funds. And in an adverse federal environment that we're currently living in, the only alternative is to try to create political momentum to counter that. So I think that's not going to happen overnight. So I think in the short term, you're right that this is a big challenge to maintain integration. But the most important thing during this very difficult period we're living through is to ensure that those individuals still have access to services. Again, it goes against what we've been talking about today about the ideal of one-stop shopping, but you have to be realistic in terms of there's nothing I'm going to say to Robert Kennedy Jr. that's going to change his policy, but maybe next time 10 million people might help rethink things. So I think grassroots mobilization, but then looking out for the needs of the individuals in the meantime, I think is probably the short-term solution.
I mean, the one thing I would also just add to that is I think this is why it's really important that we get information out to other providers who might not need to be funded federally or whatever, so they know how to provide those services in an expert way. And I'm thinking of the innovation of human beings when they face adversity. I'm remembering the buyers clubs when we didn't have access to antiretrovirals. People went out and found ways. Admittedly, they needed to have resources. People got in minibus taxis and drove to Lesotho to get illegal antiretrovirals that were generically made. People find ways, right? But then we need to know that they can do it safely. And I'm thinking this is where AI can help a lot, right? So self-care, self-help, and then making sure that other providers know exactly how to give hormones safely, maintain somebody who needs oat or, harm reduction. So we just also, again, get innovative. If the old-fashioned conventional way isn't working, what are the other ways that we can fix it? And I realize I'm a South African and we notoriously break the rules and do renegade stuff. But sometimes, as Ken says, the most important thing is that we get services to the people who need it.
Yes.
My best to hold it together.
Yeah.
First of all, thank you to all the presenters for doing such an amazing job. My name is Marjorie. So I'm a health worker and a PrEP navigator. And one of the challenges that me and my colleagues face in terms of integration of services working with a large hospital network is convincing providers that are stuck in that not in my backyard, as you put it, care, and kind of being the little person as a community health worker. Any tips or advice on sort of bringing these discussions and sharing the importance of this with higher ups and providers?
Yeah, thank you for that question. I don't think there's any quick and easy answer, but one thing is to do an environmental scan about who are the people that you're dealing with and try to see if they're allies. Because it's finding trusted peers, and so it's trying to see, they're not all self-repossessed jerks, let's hope anyway. But so it's finding the trusted allies, so it's a combination, because I think there's these models of behavioral change, and some people may be pre-contemplation, some people may benefit, making copies of the article and leaving it with them, that may be fine. But there are other people who are not going to read a paper. But if their colleague who they respect says, we really should rethink this, I think that's key. But it's the all politics are local, and I think all immediate environments, is going to be local. So it's really getting good sense of the dynamics of the people in the organization and trying to see who are your trusted allies and start with them. Do you want to go back to the questions, the online questions? Okay. How do you ensure community voices, especially from historically marginalized groups, including Black, queer, and trans individuals, inform your research and implementation strategy? Really important question. Lots of different answers. One is that having community input from the get-go is really important. So for a lot of the work we do here at Fenway, we have different community and consumer advisory boards that both help inform program. Adriana oversees the community advisory boards that inform program, and then informing the actual research, what we're doing. We have community advisory board, which is really helpful. And then having people from the community also are part of the research enterprise. So we're very fortunate at Fenway that we have a somewhat diverse group of investigators also who are doing research at Fenway, some from the communities that are mentioned in the question, so having somebody with transgender experience who's a principal investigator is really helpful as a peer to help inform other work that we're doing in the community, and having people of color participate. But
Yeah, thanks, Ken. I would just say that I've formalized it in my organization. No research is allowed to happen without first consulting with the stakeholders. So if it's research on a LGBTQI population, then those people need to be in the room. So we have community advisory boards associated with every site. But when we need specialty input like that fast prep, we have had what we call our youth reference group of 80 odd people in as expert consultants from the get-go. So they designed, co-created, and they monitor all the way along. So if we need to change a logo, we don't do it without speaking to them. If something's not working, the first port of call is go back to the youth reference group. If we need to test something, it's the youth reference group. And we pay them when they have to turn up. They get a stipend. So it's not, these are experts, they've got to be paid, and so that's been we've formalized it so that it always happens, because when you're busy and you're on a line and there's a time check, it's very easy to forget to do this. So I had to make it a rule, and people get into trouble if they don't do it. So that's the way to do it.
Yeah, Miriam, sure.
Yeah. Just wanted to add really quickly that journals have a big role to play in this, because if they're publishing research where there is absolutely no evidence that they have consulted with the community, that they've done any work ahead of time, I don't think that should be published. So that is a way to also really push researchers and the field to make these changes. And it gives the community then the strength to say, hey, you know what? Guess what? You're not going to get published unless you listen to us and have some input. So just to say, for any future peer reviewers or peer reviewers out there right now, think about that.
Thank you, Miriam. Different ways that, there's not like one answer, one size fits all. I think a lot of this are having good metrics in place to, support, to be able to know what are the current rates. So I think that's why we felt it was so important to have Andrew Grulich's paper be the lead-off paper to know what's the current state, and that those are your benchmarks to say, how can we do better in these outcomes? So we, documented the level of unplanned pregnancies, abortions, the rates of new HIV and STI, and those can be the benchmarks then for improving outcomes. And the hope is that it's not neat and easy, but it's, this whole field of implementation science, you're kind of building the plane while you're flying it, so in other words, you have those markers of where things were, you start adding intervention, which involves integration, and then you measure what the outcomes are. And there are methods, both qualitatively and quantitatively, that you can then track what is the impact. It's not the kind of thing where you can easily do a randomized controlled trial, but if you build in the appropriate measurements along the way, you can figure out what are the intended and unintended consequences, and then report on that. And that some of the literature that was reviewed today, some of these meta-analyses looked at all these different case studies and said, if you look overall at the suite of interventions, what's working, what's not working. And, I think the take home was that there are benefits of integration, but it's not like, automatic. And, so it's going to need a lot of iteration and a lot of local specificity.
And Ken, I would just add that I think we're getting some more formality into measuring the end user's experience, because I think too often, and as a biomedical scientist, I put a lot of store on, did I change the HIV incidence? Did I improve the unintended pregnancy rate? And I'm not necessarily measuring formally, has my end user had a better experience? And I think we're now starting to see better ways of measuring that, more than just focus groups or, interviews, sessions, which have had softer sort of, weight than harder evidence. And so, these tracking people's responses and people saying, how did this improve my life? So more than, beyond even quality of life surveys, I think is where the field needs to go. And here again, I think, Miriam, this is where our publication reviews can hold us to account. Did we, with the same level of robustness measure? Because a lot of the value, is going to be in that fourth 90, how somebody experiences what they've received. And the point is, it may cost more, it may take more resources, but you get a better outcome. And we need to be able to measure that in a way that works.
Wonderful. Well, I think that's a great way to end. I just really want to thank Dr. Bekker for coming so far to join us. I want to thank our stalwart colleagues who've been online, Dr. Peters, Dr. Meyer-Rath, and Jameson, Dr. Grulich, who shared his insights with us, Dr. Anderson for being here in person, Dr. Sabin. I want to thank Jen Head for her remarkable work in our technical editing assistance. And some of the beautiful graphics are definitely from her vision. And want to thank my colleagues here at Fenway Health for pulling this together, Mayor Dixon and his colleagues as well. And thank you all for your participation.
Miriam, are we online now?